participants for today's seminar, the faculty, and all those who are joining us through the link that has been provided. The Apex Trauma and Emergency Center, which is a prestigious project implemented by Government of Kerala and Tata Trust under the Directorate of Medical Education, is part of the government action plan for coordinating and improving trauma and emergency care facilities across Kerala. The trauma care is an advanced simulation-based study center where the candidate is given a hands-on experience and simulation-based enhancement of skills and knowledge in the care of an emergency situation, including disaster. World as a whole is now in the midst of various challenges, including the corona pandemic, and the healthcare workers and the public need to be prepared to these challenges. Trauma is the leading cause of death and continues to be so in spite of the pandemic. We are also aware of the fact that the global warming has resulted in climate change, and the world, from which Kerala is no exception, is in the grip of natural disasters, including flash floods and cyclones. The aim of the institution is to have a structured curriculum for training various categories of health workers. The institution proposed to train about 9,000 health workers in the first 2 years, and thereafter it will be a continuous process of training students from various streams. We have developed this as a Apex Center with about 25,000 square feet area in the first floor, and also the first floor, which is going to become, has been announced by the CM to be developed as Kerala Institute of Minimal Access Training. And this is one of the first in India to have such a major center with all facilities, including specialty-oriented training. And with these few words, and the people behind the development of the institution, including our Honorable Health Minister, K.K. Shailaja Madam, Rajiv Sadanandan sir, the earlier Additional Chief Secretary of Health, the present Principal Secretary of Health, Dr. Rajan Gobragade, and all from the DME and the Directorate of Medical Education and the Directorate of Health Services, including Dr. Ramla Bivi, who is the Director of Medical Education, and Dr. Sarita, the Directorate of Health Services. Are you playing the video? I will briefly take you through the Apex Training Center, which has been inaugurated a few minutes ago, I would say, and which is a prestigious project of Government of Kerala. The project was first conceptualized during the visit of the Honorable Health Minister to UK, the Warwickshire hospitals, and then later on, Madam had visited Thailand and also the institute at Hyderabad, from where all the knowledge about how a advanced skill center should be developed. And that marked the beginning, and that marked the association with Tata Trust. And then the EMRI has taken up the responsibility of the Kanivu, the ambulance services, which were stationed in the hotspots. And this is the building where we have housed the Apex Training and Emergency Learning Center. Thank you, and that's a glimpse of what we have in this center, and we hope that in the coming years, we will be able to achieve much more. Thank you so much, and with these few words, let me now invite Dr. Rajan N. Khobragade, our Principal Secretary Health, Government of Kerala, for his address.
Thank you, Dr. Vishwanathan. Distinguished experts from all over the world, good morning, good afternoon, good evening, because today we are in a different time zone. So definitely some of you are joining very early in the morning, some of us are in the afternoon and evening. In a lighter vein, if I have to tell you that 1.5 years back when we started to take meetings on the Zoom, my colleagues complained that nowadays sir is not calling us to the headquarters because they were getting an opportunity to come to Thiruvananthapuram. Later on in the month of December, we launched some few programs, and unfortunately, I think not only Kerala but whole world landed up in COVID in January. In Kerala, 30th of January, we landed up. What was the advantage what we had? We did not lose a single day because very next day, we were connected with each and everybody at the grassroots level. So that is the wonder of the technology. And today in front of us also another marvel, in fact, what technology can do. All of us, when we studied in medical science in our respective medical colleges, there was, I think none of us ever imagined that there will be a mannequin and we will simulate what actually is happening in a human body and we will understand the nuances of learning. Each of the medical student, in fact, if fortunate, was able to see the rarest of operation, and then if it is close to his senior or her senior, then only in fact that opportunity used to come to those chosen ones and not to the others. Perhaps that may be the reason that our skill set remained in some of the pockets, and now because of the technology, I think that barrier also has been broken. So we are in a completely different era in which each and everything is growing so fast that we have to understand that and put to use. Regarding this project, we have seen the glimpses, what we have been doing in the state of Kerala, but I would like to tell you briefly the history, which we have seen pictorially, but our Honorable Health Minister, in fact, in 2017 in October, visited Warwickshire University. The visit was organized by Dr. Vinod Menon, who is one of the guiding force who is assisting us, and they are our knowledge partner also. So in that visit, there was a discussion and Madam put forward a suggestion that in Kerala, we are thinking of developing an emergency care system, a trauma care grid. And from that thought process, the next meeting was with Lord Bhattacharya, and this was organized by Professor Sudesh Kumar, Dean of Warwickshire Medical School, and Dr. Vinod Menon. And in that discussion, in fact, it was further strengthened that let us go ahead with this project of establishing Apex Trauma Care and Learning Center in Thiruvananthapuram. From that day onwards, everybody associated with this project untiringly worked to see that, in fact, this project fructifies within shortest possible time. But for COVID, we would have started this project last year itself. But because of the COVID, we had to focus our attention on COVID and non-COVID management. And we feel at this point of time that we have also, to the best of our capabilities, we are managing COVID as well as non-COVID very effectively. And that is what we have discussed in webinar series for last 2 days. But today's topic is regarding trauma care. So with this backup support, in fact, what we have done, there was a building available here and we were looking for where we should set up this infrastructure. And immediately, in fact, we have taken a decision and almost 26,000 square feet area, we have made it available for this excellent Apex Trauma and Emergency Learning Center. At this point, I must say that Tata Trust and CHIS, the implementation partner, in fact, they have done a fabulous job which was under the guidance of Dr. Menon and others who are associated with this project, but also our previous health secretary, ACS, Shri Rajiv Sadanandan, he has been also guiding all of us in what way the trauma care center should be developed. And with those designs, in fact, which were there to guide us, we have taken those ideas forward. Now, while conceptualizing the ideas, in one thing which I have told to the team when we had a discussion and MOU signing, I told that we must visit some of the training centers in the country, and in fact outside world experience comes from Dr. Vinod and others, and we should set a benchmark that we are second to none. And today I am very proud to tell this, that we are having one of the most state-of-art facility in our country, and I do believe that this is one of the best in the country, and I think we will slowly progress it towards to the level which will be comparable to anywhere in the world. So while discussing, in fact, they told that what is the vision or what is the roadmap for us to take a look at trauma care and also this development of learning center. So my first part, I'll speak a little bit about what do we visualize 5 years down the line. Today we are in 2021. Let us imagine we are in 2026. What we would like to see in this wonderful center. What I feel is, wherever we have studied, that attachment is still with us. We remember our teachers who have taught us ABCD. We remember our teachers who have taught us science. We remember our teachers and the institution where we have studied medical science. We remember institutions where we have done our PG, post-PG, super specialization. We remember the centers where we have done the management courses and all. Our vision is whosoever comes here, right from our field level functionary, be it ASHA worker or also nurses who are working in emergency and trauma care, or field functionaries who is supporting, or ambulance driver who is taking that critical patient immediately to the center. We believe that each one of all these people will always have the attachment with this institution, thinking that it is not the government institution, but it is my institution who has honed my skills with respect to the extension of services to the much needy patient who are otherwise on the verge of death, and from the jaws of death we are bringing them back to the life because of the training inputs what we have received from this center. Now, if we have to fructify that, what we need to do, our vision is we should have this methodology of breaking these barriers of distance and time. So we look forward to the arrangement or the grid of learning center in such a way that in every district there will be a node, and from that node, the resources or the capacity which was built of the state level master trainers at a district level, they will be utilized, and we will have observation sessions from here so that we can give inputs to these master trainers, and through them, series after series, we would like to have this capacity building get going. This is the way we will roll out our capacity building program in such an efficient way that we should definitely be able to break this barrier of distance and time and make it so user friendly that each one of them will definitely enjoy those training sessions, and they will have the facility to keep on refreshing their knowledge as and when they are not very busy. So that is what the concept of continuing learning education, what we feel that we will have such an interactive website or web portal that those who are associated within the state, outside the state, within the country, or outside the country, in fact, we will definitely see to it that we will try to help that their learning capacities also goes up with such seamless arrangement which is not having any boundary. Because today we are living in a global world. We don't think that we are a part of one particular state or nation, but we feel that we are part of this globe. And that is the message COVID is giving all of us, that if we have to think big, we have to think big, and we have to see that whatever expertise and knowledge which is available as not having any boundaries, And therefore, we have to break those silos and ensure that this knowledge and skill sets are gone far flung in the grassroots and all the levels. That is our vision, that this center will stand out over a period of time, that there will be many more associations within the country and outside the country. And our whole plan of having this international webinar this year is to make Kerala Health as a knowledge hub management. And from this hub, we will associate with whatever expertise and whatever institutional collaborations are available, we will associate with each and everybody and go forward. Whenever I discuss with DME, DHS, SMD, and everybody, my colleagues, Dr. Vishwanathan or Shrikant or Ashil or anybody, I tell them that, our objective is we should have 500 Vishwanathan, we should have 1,000 Shrikants, we should have 1,000 Ashils. What do I mean by that? The capabilities which are there in such dedicated people, we should have a mechanism and enabling environment by which we will have such thousands of people amongst us, so that whenever there is anybody needy, we should be reaching that person in such an efficient way that we will establish through our work that we really value the cost of the life. And when we say that life is precious, we will realize that what is the responsibility entrusted to us to do what we are expected to do. So this is our vision of this institution. Now I will come back to the little bit of functional part. What we have been doing in this center is, we have studied in Kerala what are the black spots. We have studied the data, and that Herculean effort is taken by Dr. Shrikant, Dr. Vishwanathan, Dr. Ashil, and we are having a digitized map which clearly indicates which are the spots which are more vulnerable, by which we will have the accidents, and accidents are happening. So our data suggests that annually, in fact, there are around 30,000 to 40,000 road traffic accidents happening on Kerala roads. And out of that, on an average, 8 to 10% persons are succumbing on death. We have done the causal analysis also, and most of the time it has come to our notice that the cause is delayed arrival in the healthcare setting. And therefore, in all these 350 black spots, we have to do the chain of, what is the chain of event? Accordingly, we have to do the intervention. So our planning related to the functional aspects is, after identifying 350 black spots, whether we are having ambulatory services. So our government has taken a decision and outsourced that system, which we call it the 108 ambulance services. And through that, if any road accident happens, we take the patient to the nearest hospital. So there were two challenges in this. Shall we provide the much needed care only through government health care infrastructure, or we should build partnership with the private? We have built the partnership with the private sector also, and there are very good packages in our insurance scheme, which are the additional packages from the state government over and above what Ayushman Bharat insurance scheme gives. In our insurance package, there are around 1,700 packages. Out of that, 100 packages are exclusively for secondary and tertiary care, which is the contribution add-on over and above what national insurance does. So that is the commitment of the government on a policy front, and that is the commitment of all the functionaries at the implementation level. So having dealt with this issue of whether we will take this patient, whether we will take them to the government setup or private setup, that we have sorted it out. Then come the real issue is whether the functionaries are there. Unfortunately, in fact, everywhere the picture one reads or sees is there are a lot of vacancies in the government setup. But I am sorry, it is not the case of Kerala. When we have rolled out this program, at that point onwards, in fact, gap analysis was done, and more than 500 posts of super specialist, nursing staff, support staff have been created. So what we do in Kerala Health is, we take a look at everything and we close the loop. We don't do anything in bits and pieces. So by providing human resources also not sufficient, and therefore we have to ensure that their skills and the knowledge are completely at the cutting edge and contemporary, and therefore they will be provide the most efficient services to the patients. And from that thought process, we are now witnessing one of the most equipped training center in the state and perhaps in the country. Those are the functional aspect. But we don't stop here. We look at what are the causes of the road traffic accident. And we do focus on the prevention aspect. And we do feel that by prevention aspects, also we will be thereby reducing the very requirement of the provisioning of this service. But that doesn't mean that we will not have these services and infrastructure. What do we do about the prevention? For the road improvement on a scientific basis, all the studies have been done, and through our KIBBI project, we are around 40,000 crores we are investing in doing the infrastructure. That is not only in the roads, but I am saying there are components. So the investment is going in health infrastructure, investment is going in the road infrastructure, investment is going into the railway over bridges, investment is going into the building new bridges. So we take a look at what are the prevention aspects we should do. Not only infrastructure, but then we engage with the community and we tell them regarding the bringing in the discipline regarding the road discipline. Obey the road traffic sign, we call them the road furniture in a technical parlance. Look at those signages, look at those messages, and then one should be definitely abiding by all the rules and regulation by nature. It should not be by default. In fact, one tends to jump the rules and regulation. So we engage with the community, and we are very fortunate that Kerala's social strength in terms of literacy, Kerala's social strength in terms of very good, very strong local self-governments, and Kerala's social strength is building the public action is unparalleled in the country. So these are the strengths of the Kerala and with which we go forward. And these are the functional aspects. I will sum up that we have put up the strong foundation. And as they say, that journey of 1,000 miles starts with a single step. We have taken that step. I'm very confident all the experts, Dr. Bhoi, Dr. Patanjali, Dr. Ajit, and many more who are now going to speak in this webinar, they will not be only the guest speaker, but they will become our partners in the days to come. Dr. Menon and all will be always our partner because Warwickshire NHS is our knowledge partner. So we look forward to association with all these experts and the luminaries in this field and strengthen this institution to a completely different level. Thank you very much.
Thank you, sir. Thank you for those very informative session. And now I invite our country representative of the WHO, Dr. Roderick Koh-H. Offren, who joined India as a WHO representative from July 2020. He was earlier the Regional Emergencies Director for the Southeast Asia region, providing strategical guidance and operational leadership to ongoing response to the global COVID-19 pandemic across the region. He has been associated with WHO since 2002 and has served in multiple roles, starting as Public Health Officer in the war-ravaged island nation of Timor-Leste, assisting in setting up of its health systems. From being involved in the response to the Indian Ocean tsunami, a mega disaster that impacted multiple countries of Southeast Asia, Dr. Offren went on to lead WHO's response on the ground during major events such as cyclone in Myanmar, massive earthquake in Nepal, the Ebola outbreak in Liberia, and most recently the Rohingya crisis. He was born in Philippines and holds a Doctor of Medicine from the University of Philippines and a Master in Public Health from the Hebrew University, Israel. Over to Dr. Roderick Koh-H. Offren.
Good evening, everyone. Shri Pinarayi Vijayan, Honorable Chief Minister of Kerala, Srimati K.K. Shailaja, Teacher, Honorable Minister of Health, Social Justice, Women and Child Development, Dr. Rajan Kobragade, Principal Secretary, Health, Government of Kerala, esteemed officials from the Government of Kerala, representatives from partner agencies, delegates from healthcare institutions, ladies and gentlemen, good evening. It is my real honor and privilege to be here with all of you today. First of all, I would like to congratulate the Government of Kerala for shining the spotlight on trauma and emergency care, which are extremely critical components of the healthcare service delivery ecosystem. I think it is commendable that that the Government of Kerala is both restructuring and strengthening the trauma care ecosystem based on a gap analysis and a vision plan. Dr. Rajan has just outlined everything. It's very difficult to follow through after his speech. But what we see is that the gap analysis has become the basis for the setting up of this trauma care, not just a training center, not just filling up empty posts for specialists and healthcare workers, but altogether thinking of this as something that is linked to each other and the whole health system. Number two, the setting up of an Apex Trauma and Emergency Learning Center to produce a trained cadre of healthcare professionals across a spectrum of specialties. Again, it is a well-designed emergency services. Well-designed emergency services facilitate timely recognition, treatment and management of the injured, and when needed, continued treatment of the acutely ill at the appropriate level of the health system. Meaning, even if you need rehabilitation after, then that is all well thought of, from prevention to rehabilitation. The way you might think of a huge disaster where you do risk reduction, prevention, preparedness of a system, readiness of a system, response of a system, and recovery. Ladies and gentlemen, road traffic injuries are among the leading causes of death globally and in India. However, injuries or trauma result not only from road crashes, but also due to falls, burns, drowning, animal bites, snake bites, poisoning, and violence. All of those, a vast majority, are actually preventable. Once injuries occur, robust trauma and emergency care systems can prevent deaths and disabilities to a huge extent. Trauma and emergency care are vital to achieving universal health coverage, a key element of the Sustainable Development Goals, specifically SDG 3. SDG 3.6, that's the goal and target, aims to reduce the number of injuries and deaths due to road crashes by 50% by 2030. It's not as if we're starting from there. The previous decade, the decade in 2011 to 2020, the decade of action for road safety brought a sharp focus to post-crash care as one of the 5 pillars of intervention, which includes road safety management, safer roads and mobility. It begins also with better road design, safer vehicles, those with seatbelts, airbags, etc., safer road users, and post-crash care. The Stockholm Declaration 2020 called for a new global target to reduce road traffic deaths and injuries by 50% by 2030. So we're in this next decade right now. The UN General Assembly in August 2020 proclaimed 2021 to 2030, we're off at the right start, as the second decade of action for road safety. So we're in the second decade and still injuries and road traffic accidents are still the #1 causes of death. There is this urge for fast tracking the shift to safe, affordable, accessible, sustainable modes of transport. including public transport, cycling, walking. It's supposed to be a whole ecosystem that prevents a road traffic accident, that even if you cycle and you walk, you're safe. India has adopted the UN Decade of Action for Road Safety, both for the first and the second decades. Now, that's a global scenario, global targets. Where are we with the Indian scenario in building a responsive emergency care system? I think let's focus on that point, as this is the topic of the webinar. Among the various injuries reported in India, road traffic injuries are at a level of a public health concern. As per the Ministry of Road Transport and Highways report for 2019, road crashes killed 151,113 persons in the country. In that, the state of Kerala had reported 40,000 accidents, fourth among states in India. However, look at this number, 4,000 road crash deaths only, which brings the state down to the 16th, meaning there is some point there where, yes, the accidents happen, but the deaths don't. Maybe more data is required in terms of looking at this better. How many were disabled, how many are disabled for a lifetime, how many recovered. But it means that there is investment in emergency care, and that we don't lose the people who are involved in the accident. So we're starting off on a very great footing, plus the vision that has been outlined by Dr. Rajan. The government of India has adopted the 50% reduction in road crash deaths by 2030 as part of its commitment to the second decade of action of road safety, as well as SDG 3.6. Indeed, adopting a target is an important first step, but the question to ask is, how do we get there? The next critical step includes devising a clear roadmap or action plan with clear indicators that will take us to the target of 50% reduction. After all, what gets measured also gets done. The roadmap, what do we mean by that? It's an overly used term, but for picking up from some of the points of Dr. Rajan, it is a multi-sectoral road safety action plan. It's to provide a framework for a common goal and shared vision to various ministries in government, to all stakeholders to engage and contribute in their different capacities in the prevention of road crash injuries, as well as in post-crash care. So we look at the cycle of preventing the accident, preventing the injury, the response to such an injury, the recovery from such an injury, should all be in place. And it's not just a health issue. Many of health issues are actually have their roots in other sectors as well. If you don't have safe water and sanitation, then you get, let's say, an outbreak of diarrhea. If there are no safer roads, well-built roads, well-educated drivers and citizens who drive, a system for public transport, then road crash injuries are not far. So from the risk reduction prevention to the response of a health system through its emergency care system to the recovery of a patient, it's all connected. And I think this is the biggest message. I would like to reiterate the significance of an integrated approach to the problem. If there's anything COVID-19 pandemic has taught us, it is that a health system can only be resilient if other systems are resilient as well. Trauma and emergency care must be an integral part of comprehensive primary health care delivery system, also known as an emergency care system, to be both effective and cost-effective. An emergency care system delivers time-sensitive healthcare services for acute illnesses and injury across the life course. It extends from care at the scene through transport and emergency unit care to early operative and critical care when needed. And WHO promotes universal access to safe, high-quality, need-based trauma and emergency care for all within a broad health system, unit care and financial risk protection as part of universal health coverage. We also heard Dr. Rajan explain to us the additional financial risk protection from injuries as part of the inputs from the state government of Kerala, apart from Ayushman Bharat benefits. The COVID-19 pandemic has highlighted the necessity for integrated approaches to preparedness and response to acute illnesses and emergencies. It is a whole of government and a whole of society approach. I think I will start to conclude. So there is more time for really the discussions of the meat of bringing to fruition this visionary plan for trauma care. WHO continues to promote and support a multisectoral coordinated response, as I have mentioned, to prevent road traffic injuries and improve trauma care through an integrated approach. Several different agencies, ministries, parts of society have a critical role to play in this, including police, health, education, transport, civil society organizations, as well as the public. Please do remember that communities and the public are part of the response. The public in public health is often forgotten. In public health, we always turn to experts. Even in the control of COVID, we are looking towards the public to engage because they are part of the response. Just look at COVID appropriate behaviors, look at driving and seatbelt behaviors, how much deaths have these prevented, or how much they have cost if violated. As an organization, WHO, especially WHO India, will continue to work with the government to provide the necessary technical support for the success of trauma and emergency care across this whole continuum. To this effect, WHO tools for strengthening emergency care systems have been made available globally. We can work together with partners and all stakeholders in India, and of course, specifically the state of Kerala in this effort to contextualize this to the needs of the state. In addition, a report, Strategic Directions to Integrate Emergency Care Services into Primary Healthcare in the Southeast Asia region, was published by WHO CRO in 2020. Dr. Patanjali is speaking in this webinar, and he'll tell you more about this. Towards the end, I would like to reiterate that measures being taken by government of Kerala to set up an apex trauma and emergency learning center and strengthening trauma care system will go a long way in saving lives and setting an example to other states in the country or other countries. This will bring in rich dividends in terms of reducing trauma and emergency-related deaths and sufferings and disabilities. Thank you again for the invitation. My best wishes to all of you for the deliberations ahead. Again, thank you for your time and attention.
Thank you, Dr. Rodrigo Afrin, for those kind words and also for giving us the support, promising us the support for strategic direction and also in our endeavor to achieve the best possible in trauma care. Thank you so much. And that concludes the special addresses by dignitaries. And we are into the panel discussion for on trauma. And to moderate this, I now invite Dr. Sanjeev Boy of All India Institute of Medical Sciences. He is a gold medalist in his university and a real gold, or a gem I should call, as far as trauma care and setting up or organizing the trauma setup in India is concerned. He is currently the professor at the Department of Emergency Medicine in All India Institute of Medical Sciences. And he has been appointed as the head of WHO Collaborating Center for Emergency and Trauma since 2018-19. Dr. Boy has received the prestigious Michael Moles Fellowship from World Association of Disaster and Emergency Medicine in Victoria, Canada, and has been elected as director for the board of directors of VADM in May 2013. A vast experience in emergency medicine, and he presently serves as a technical expert to the Government of India for establishing a robust emergency and trauma care system. A good friend of mine and also a well-wisher, I have great pleasure in inviting Dr. Boy to join this uh, seminar as moderator for the trauma care specific development guidelines. Thank you so much, sir. And I request you to take over and moderate the discussion. Thank you very much.
Yeah. At the outset, I thank the government of Kerala, Ministry of Health and Social Justice, the Honorable Chief Minister of Kerala, Sri Peniel Bijayanji, and the Health Secretary, the current Health Secretary, Dr. Rajan, and the previous Health Secretary, uh, uh, and also all the colleagues from Kerala. Especially must thank Madam Shailaja Teacherji, who had given me opportunity to work with my team with the state of Kerala. Kerala has been in the forefront of developing newer systems in the country and has always shown the light to the whole country, whether it is literacy or other sectors as well. They are in the forefront. So that's why it is very exciting to develop models in Kerala and scale it up to the other parts of the country. So it was very enlightening discussion and a very heartening moment for us also that one milestone has been achieved. Is the key thing which changes the direction in actually seeing changes in the ground in care delivery is actually capacity building. And this is one of the key components of making a change in care delivery. So if you see, I'll just focus a little bit, before setting up the stage for today's discussion, that today's discussion will be Kerala Health making a sustainable development goal a reality in trauma care. Recently, we have finished or conducted a facility-based assessment in emergency care. Emergency care in the country, emergency and injury care in the country, across 100 facilities in the length and breadth of the country. And it was funded by NITI Aayog along with AIIMS. And you'll be surprised to know there are the huge gaps or challenges in the emergency care system. With the current system, there a lot to be desired in lack of trained human resource, lack of supplies, and lack of actually processes which are there existing in both secondary care level hospital as well as tertiary care level hospitals. So one of the key things which can change, game changer which can be shown on the floor, is developing good capacity building, and second, having an integrated approach in emergency and trauma care. We found best practices like state of Tamil Nadu, where actually they had integrated 6 pillars. That is, both trauma and emergency goes hand in hand. If you see, you are going to manage a good post-crash care, but should be equally caring. The system should be responsive to acute MI or a stroke patient, stroke, STEMI, trauma, sepsis, maternal child health. So both acutely ill and injured will benefit if you develop a robust system. There'll be, you can benefit. If you develop a one system, part of the system, the whole system will benefit. So, and if you see the WHO World Health Assembly recent statement in 2019, the resolution which was passed there was to have a emergency care, to a well-organized emergency care is actually responsive or quick responsive to integrated approach rather than systems in silo. Yes, trauma is a huge problem and it affects the young people, and sole breadwinner of the family is affected. It is really a matter of concern. So with this perspective, I know we have already, our previous speaker has put the perspective that there is a lot of death and disability in the country and is still underreported, as well depicted by our previous speakers. So with this burden, let us discuss how we can go ahead and develop an integrated system. So now with this initial remark, we have various luminaries on the panel today, from Dr. Patanjali Dev Nair to Dr. Ajit Abraham to Dr. Ashil, Dr. Ramana Rao, Dr. Vinod Menon, Dr. R. Ravindran, Dr. Srinath, Dr. Somaraju, Dr. Sagar Galvankar, Dr. Venkat, and Dr. Sriram, and Dr. Vinod Menon again. So I will individually, introduce them one by one. But now I'll call upon, without wasting time, call upon Dr. Patanjali Dev Nair, who is senior advisor to CRO WHO. With him, he is a friend, philosopher, and guide, in the quest of developing integrated emergency and trauma care system in the primary care. And he was the lead, actually shown the light of public health to a clinician who is working on the floor for trauma care last 10 years. So, and he also serves as, actually, he's given his expertise in this field since last many years, and he believes in action. So I'll invite Dr. Patanjali Dev Nair, to give his talk on strengthening strategic directions to integrate emergency medical services into primary healthcare. Over to you, sir. Dr. Patanjali Dev Nair, sir.
Hello, can I get connection, please? Yeah. Hello,
Sir, you are audible.
I'm audible, but I'm unable to. Now, how I have to move is with my slides. So I need the rights
Sure, sir.
and also the
Dr.
camera.
Vishwanath, please make Dr. Patanjali as the co-host.
I had requested them earlier also. Exactly, so that no time is spent. Thank you very much. In the meantime, if you all can hear me, I will speak about it and thank the government of Kerala, the Honorable Chief Minister, the Honorable Health Minister Ji.
Excuse me, sir. Patanjali, sir. Your
Right.
camera is not on. Could you please?
I'm unable to see the camera button here.
Down, there's one start video camera button, sir.
Of course,
On the screen. On the screen.
I do many.
On the left-hand side bottom, you will see start video. Along with that, unmute.
I only have this button. I don't know why it has happened.
Close to that, you will have start video.
I'm not able. I assure you, it's not visible. I don't know why. Really amazing, because mute button is available.
Sir, the camera maybe.
Sir, can you touch the lower side on the left side? If you touch, you will see a picture of a camera and a red
I
line.
know.
And
The whole point is maybe.
okay, in that case, please continue. We can have your audio at least. Thank you.
Yes. Now I can see. Yes. Thank you. Can you hear me, sir? Sir, can you hear me? Sanjeev ji?
Yes, sir. Yes, sir.
We can.
Yes, sir.
Now I got the rights. Now I got the camera also. And I'm going to share the screen. Thank you very much.
So please go ahead.
Yes. Is the screen visible, sir?
Yes, sir, it is visible.
My slides are visible, sir?
Yes, sir.
Okay. I apologize with the folded hands of having spent 1 minute of your precious time. But as I was thanking the government, and I was especially enlivened to hear Dr. Rajan speak so well and about the milestones achieved and the points raised. I would also like to remind what he said about how do we reach out to the people who have trauma, and then Dr. Rodrigo, our WR, who most eloquently pointed out that what we need to do is integrate the system. And that's what I'm going to speak on as introduced by Dr. Sanjeev Bhoi, is the whole issue. See, if you have to move on, we don't need trauma centers everywhere. What we need is trauma services. And for trauma services, there are many things which are common, as Dr. Bhoi has said, which should also cater to maternal and neonatal health services, as MIs or other medical emergencies. So there's a synergy. And that is what we are going to speak about, how in my next 9 or 10 minutes that are given to me is on these, is the point, is how do we integrate the emergency and trauma care services in primary health care? And it's a call of the times. That's what we're going to talk about. And I assure you that Dr. Rodrigo has already laid the basis for this talk here. Okay. Sorry. This is what is time sensitive for acute illness. In injury across the time steps, only if you work towards this area. That is, it extends from care of the scene through transport to the emergency care unit. And it saves lives, and it's crucially important for the on-scene transportation primary facility levels of care. This is what the ECS emergency care system is all about. This is a simple flow diagram which talks about the emergency care system framework. You see, it's also, you can replace the word trauma with emergency or synergize. You find the similar system there. At the scene, what can be done, during the transportation, what can be done, and at the facility. So we'll talk about all three, and the facility will divide. We really want to cater to the first level and the second level facilities so that the patients don't have to move only to the third level facilities, because at times resuscitation is required and other times stabilization is required. And that is most important rather than at the scene or at the first facility itself. Emergencies, in the emergency room, 15 leading causes of death and disability come to an emergency room. So, or the emergency care facilities. So that's the one. Trauma is only one of them. So if you have good emergency services, you not only save lives with trauma, but you also save lives with other 15 causes. Usage varies. And that is where we're going to, I think Kerala will do better. This is one of the most important lines I want to bring up. Low income countries, there's a median visit of 8 visits per 1,000 population. In the high income countries, 264 visits. So we are definitely lacking in something, that the people are not coming to the emergency services, or the emergency services are not geared enough to cater to the people. And that is where we've got to find out, as Dr. Rajan said about the gap analysis. I think it's an excellent presentation, and the viewpoint coming through is a pleasure. And as Dr. Rodrigo, my colleague and friend and our WR said, is here. This is where people may access emergency care at multiple levels of the system. If there is a good primary healthcare system, it caters to some emergencies at least. You cannot cater to spinal cord injury at the primary healthcare, but you can definitely stabilize a person there. And that is what we're going to talk about in integration. What can be integrated? What can be done at the site during transportation and at the first level facility? Because patients will come at every level of facility. At time, you have a tertiary level system receiving a patient who could have been well managed at a primary healthcare system, but they have chosen. So patients have a reason and a choice and the right to visit. And our job is to see that, can we save lives when we are already doing so much? It's an excellent presentation which came through both from Dr. Rajan, Rodriguez, and Dr. Bhoi. This is the resolution Dr. Rodrigo was referring to. And it talks about integrated emergency care services. It says emergency care services again, not trauma services alone, because it's added on to the area. Many times we have seen Dr. Rajanji and Viswanathan. Of course, we are very, very proud of, again, Dr. Viswanathan, the way you have managed out and done things, is that we see that there are fiefdoms created. That somebody says, no, I'm only spinal surgeon, I'll do spine. You lose out. So how do you get the synergy from the system, as Dr. Rajan said, that they included the private people also, the government and multiple areas, all stakeholders. And as Dr. Rodrigo said, we got to go to the community. That's real integration. This is about second decade of action for road safety, already talked about. But why I added the slide, here is the last para, which is, and also 3 lines which are read. It says, the UN second decade itself talks about pre-hospital care, including emergency health services and immediate post-crash care response. So the second decade of road safety has understood that the pillar 5, that is the post-crash care, including pre-hospital care, is one of the most important things, and that is why it has been brought up. That's the reason for showing these slides to you. As I said, we need trauma services, not trauma centers. And trauma services can be given from a good emergency services center. This is an excellent slide, which I want to spend 30 seconds on, and largely to concentrate on the right-hand side, the yellow ones, which talks about how low-cost intervention can save many lives, especially the ones related to trauma. I changed them and brought them on the left side, pressure bandaging, cervical stabilization, etc. And I've also added pulse oximetry because of COVID, which is there, but we are collecting more evidence. So that's the reason I've added it. This is one of the best diagrams, and I like to thank Dr. Bhoi, Dr. Tej Prakash, and others. This is picked up from the our publication, which kindly our WR, Dr. Rodrigo, referred to. This is what is meant by integration. We don't mean that everything is to dome at every place. We understand the roots of this tree come from various places: poisoning, snake bite, trauma, respiratory emergencies, chest pain, stroke, maternal, etc. And then they go through a trauma common system of ambulances, of triage system, of then finding out, and then they go to the specialized services if needed, because a lot can be managed by a non-specialized service. And that's why the branches of the tree are the specialized one. But a lot of things can be done at the main branch, at the main stem is there. And that's what the integration is all about, that people with various emergency needs, that's the roots, come at a common point. If they manage well there, that's fine. Otherwise, then we suffer the ones which require services, specialized services to specialized area. We don't have to send everybody to a specialized neurosurgery center just because the person fell down on the road crash. That is where integration helps us. And a simple diagram of this kind of a tree, which is there, which you want to talk about. What are the advantages? Huge integrated emergency care and save lives and maximize. Is there anything else we require more than this, the first line itself, that can save lives? Okay, but then we still have, it reduces dialysis and mortality. It promotes equity, because by this we provide services to everyone. There's nobody left behind. There's nobody who's in the rural area or far-flung area of Kerala or anywhere else. That is equity. It's a system safety net. People are able to come to the emergencies and manage, even if it's a non-emergency at times. It's a safety net. It doesn't let an emergency develop. If somebody has a small chest pain, if it comes right away from with angina, he doesn't progress to a mitral myocardial infarction later on. That's what. It fills in the UN commitments, COVID-19 pandemic and beyond. It will help us better. We have learned we need emergency services, good emergency services, quality emergencies for managing COVID or anything else which comes next time. This is not the end of infectious diseases, sirs and madams who are listening. We're going to have other epidemics, pandemics coming in. We got to be ready for them. And of course, for the achieving multiple SDG, which is the next slide, talking about, this is talking about the burden of disease that can be addressed by pre-hospital emergency care. So you have all of them. So why not we have focusing on having good emergency care system? When you can, so many of them, you can see down, if the slide is clear, all those conditions, and which some of them I mentioned earlier in the slide, can be managed by this area. And that is where we're going to save lives. Today we're talking about trauma, but all of us with the health system are in the business of saving lives and then providing rehabilitation if needed. That is where integrated approach from the beginning helps us. And of course, the trauma services would be much strengthened, which has happened. We compliment the government and all of you for having this APEX center, which I'll talk about a couple of slides later on. It's an excellent idea coming through. But we also need to see how do we integrate, and a clear capacity is built of not only managing trauma, but managing various kinds of emergencies and having the infrastructure there. This is the various SDGs goals, and the red UN 3.6, which Dr. Rodrigo also mentioned is the area. is for the, lastly, post-crash cares and trauma, etc. coming up. Here is the goal plan and the ECS integration. Very simple. Seamless integration. What is the input? Governance, finance, human resources. What is the output? Integrated ECS, quality. What is the outcome? Universal access to ECS, seamless referral, good referral, improved in mortality, morbidity, and dialysis. Why wouldn't we do it? And the impact, huge on the SD goals, healthy populations, improved dialysis. So simple way of showing that if our inputs are correct, and we talk about it there, we got to have a great impact. The other two in the middle of the process. So inputs are these, impact is there for all of us to see. And I'm sure that a progressive state like Kerala, and what I have heard of from Dr. Rajan today, and of course, have had interacted with Honorable Health Minister K.K. Shailaja Teacherji, also when she was in Konkan and Viswanath, we are very sure that we are already in the path. We would like to recreate and assist in this movement so that we actually have good impact. Challenges are many. I will not go through the whole list, from administrative to information to public, which Rodrigo also mentioned, transport, economic, human resources, training. This is just a list. Of course, these slides are for everybody's usage. You can do that. And I've deliberately added in blue the ongoing COVID-19 epidemic and beyond. That has been a new norm, which is coming up, new normal. We got to understand it brings new challenges. That's what's being called as new normal. This is where I want to thank, compliments to the government of Kerala, to Honorable Chief Minister, Honorable Health Minister Ji, Dr. Rajan, the Principal Secretary. It's a pleasure. Of course, my Dr. Viswanathan, whom I saw through camera when he was in Konkan and other places. And we would like to collaborate further with the Apex Center. We'd like to say here, we seek the Kerala experience and what we are doing, experiment, for bringing it not only to other states of the country, but other countries of the region. We like to do that, and possibly we'll speak about it a little later, on another day. Like lead agency, you already have the Apex Center there. So this is how to integrate. One is the trash shifting. We want to talk about it. Unless you build capacities, but capacities of whom? If you're going to give our nurses only the same task which we gave earlier, when they're such capable young boys and girls who come here, we are not using them well. So we got to shift tasks and see that we bring up some of the things as the area. Secondly, we also got to use technology and innovation for some repetitive tasks, some other things area, smartphones, telemedicine, training, artificial intelligence, and apps. A lot of these. In the next slide, I'll show you some photographs, utilizing robots. And, of course, it's going to require some policy changes, but I'm sure the government of Kerala would be one of the first one to see that, to bring forward changes in the policies and SOPs to see that we are able to task shift and utilize technology. We have less people. Where are we going to get more surgeons, more anesthetists? We are not going to have too many of them. So we got to understand how to utilize the manpower better, and this is what we're going to do. And here are some just random. I have around 100 of such slides which talks about robots, AI, and the middle one is this robot can draw blood, and with 100% success, of course, it's required. At the moment, we would like to use where these are difficult to draw blood in some patients, which can be given to robot and other ones. Huge number of them. The idea is just to whet the appetite of my colleagues here to say that the time has come for India to utilize technology of various kinds. As my previous slide said, smartphones are the biggest technology we can use for even showing ECGs or doing retinal scans. Bangladesh is doing it, so I want to bring it to you as an eye surgeon, which I know that Bangladesh is now making nurses take a retinal photograph with a smart camera and a new lens, which gets transported back to a diabetologist or a diabetic expert, diabetic retinopathy expert. Just 2 minutes of your time, which I will not read, is that the building blocks for every building, as Dr. Rodrigo said, and Dr. Rajan alluded to it, we got to bring about some changes and look at some of the points in all the 6 building blocks of the health system. As Dr. Bhoi alluded, we need to do that. And the points have been given here largely, some of them deliberately in red. What I want to say is, without going into detail, that for integrated system, the building blocks are the best example. They already exist. We got to add trauma and emergency there and see to it that integration takes place. Facilities are available, buildings are available, ambulance is available. But why should be utilized only for one thing? Why should there be a separate ambulance for children's hospital and one for trauma, and both lying idle for some time and suddenly both being required? We got to bring them under one load. That's where the building block of leadership and governance comes in, etc., etc., etc. And that's also the next slide for all the 6 building blocks we're talking about. My last 2 slides here on this is the strategy for integration of it. And we have a 4-step process. And I really here, I hope Dr. Rajan and other seniors are listening here. Simple thing, and which you talked about, is the first step is already done. That is the gap analysis, situation analysis. But we need to enlarge it to many other emergencies. And we have the tools, which Dr. Rodrigo mentioned, and I will again go to a slide I've added on so that you can look at those tools at leisure. Then you develop a strategic plan, as Dr. Rodrigo said, way forwards. So how do we move forwards? We move forwards only when we are clear what are the issues, and then what are we going to prioritize? There are 100 issues dealing with every government. So you got to prioritize and say, look, these are the bigger gaps. I was very happy when Dr. Rajan mentioned that they found the black spots around how many, 500 or so of them, and working on there. So that is where the prioritization taking place. The third step is establishing monitoring evaluation processes. Most important, mention that what is measured gets done. And fourth is implementation and the rollout of the strategic plan for capacity building, which you're already doing. These are the tools, and this is available. All these tools are available at the site I've given below from the WHO, all is there. And this is my last slide with thank you, is to show you on the right side what I showed on the first slide. This is the strategic direction to integrate. Many of the points which I brought up today are taken from this. Some are new because things have happened even after that, especially made for Kerala state. But this is where, and I've shared with Viswanathan so that all the participants can have a copy of it, PDF copy of it is available. And I want to thank Dr. Bhoi, Dr. Tej, Dr. Vivek, and many others, such as Dr. Sagar, who contributed to the meetings which we had in Thailand, and then followed up. A large number of people from Thailand, from Sri Lanka, Bangladesh, and of course from India contributed to this. As you know, WHO comes up with books and periodicals and documents which are made by experts. And this is one such document I present to all of you, especially with humble regards to the government of Kerala to utilize it further. I stop here. I will thank you very much. I won't take it longer. Thank you very much for inviting and listening to us. Pleasure. Thank you.
Thank you, Dr. Nair, for such an excellent way of explaining, what is actually the way ahead. We really had, a national gap analysis, facility-based gap
Are
analysis.
there any questions? Thank you very much, sir. Thank you for those that presentation. And I'm sure, as we rightly said, the WHO will associate with us for a long-term, on a long-term platform, and definitely will take us forward. And thank you very much, sir, for those nice words, and also help enlightening us on how at a primary level the strategies have to be evolved. Thank you very much. Dr. Sanjeev Boy is there, sir?
Yes, Dr. Vishwanath. Yes.
Shall we go on with the next speaker?
Yes, we can go ahead with the next speaker. And the next speaker is Dr. Ajit Abraham, consultant trauma surgeon. He's a trauma surgeon at Royal College Hospital, NHS Trust, UK. And he is going to speak on the provision of trauma and emergency surgical services at basic level. So over to you, Dr. Ajit. It is a pleasure and honor to introduce you. This is Dr. Bhoi here from WHO Collaborating Center. Welcome you, sir. Please go ahead.
Can you see the presentation?
No, sir. It is not visible. You're audible,
Sorry.
but slides, yeah.
Is that better now?
Yeah, yes, sir.
Okay. Thank you very much. Good evening, everybody. Honorable Chief Minister Sri Vijayan, Health Minister KK Shailaja Teacher ji, my dear friend and Principal Secretary Dr. Rajan Kopragade, Dr. Boy, it's a great pleasure to see you, and also Dr. Patanjali, Dr. Rodrigo, and so many other esteemed colleagues. I feel a great privilege in being part of this conversation today, particularly as I'm a son of Kerala, and I'm hugely uplifted by the work that is being done in the state in the service of the population. So I have been a trauma surgeon at the Royal London Hospital, which is one of the major trauma centers in London for 16 years now, and I trained there as a registrar in 2000. So in some ways, I'm uniquely privileged to have seen the evolution of a system for trauma care provision over the last 2 decades. And so we have gone very much from a somewhat broken up, non-integrated system to being what is now considered a world-class trauma provision, of which I'm very proud to be a part of. So I'm really going to offer some perspectives and some learning from some of the things that we have had to encounter and develop over time, and hope that provides some useful food for thought for our discussions. The other thing that I'm privileged to do is we are now forming integrated care systems in the UK NHS. And one of my current responsibilities is to help shape and redesign the provision of emergency general surgical care across the Northeast London region and into Essex. So in that sense, it's a very timely opportunity to share some of the thinking with you, and also to learn from everything that's been done in the Kerala design process. I am very grateful to Dr. Patanjali for such an excellent talk. I was very happy to read the document that was kindly provided by Dr. Vishwanathan, the CRO document from the WHO, and I think I will just use that to inform some of my conversation. I'm proud to be at the Royal London. We were the first MTC in London. We had the first helicopter provision. We have pioneered some of the work around the blood transfusion aspects of trauma care under the expertise of my colleague, Professor Karim Brohi, who leads our Center for Trauma Science. And we have an exceptionally strong pre-hospital medicine university provision, and some exceptional colleagues in the emergency services, as Dr. Boy, I'm sure, will know. So we have a system from which I think much can be learned. I think this framework that Dr. Patanjali has also already shown is an excellent one. I found it very helpful for clarifying my own thinking. And as he quite rightly said, you can quite simply substitute the word trauma for emergency, and you have a similar sort of approach. And I liked these, not to repeat what Dr. Patanjali has already said, but I like this way of thinking about the integrated model. So many speakers from Dr. Rodrigo onwards have highlighted the importance of the word integration. And this is something that we have definitely learned to do better in the NHS. So this is not just in the context of emergency care provision for general surgical problems, but also for things like trauma. And you will all be, I'm sure, aware of some of the significant gains that have been achieved through the provision of acute stroke services, and also integration of acute cardiac emergency provision as well. So there are gains to be made from this system approach. I think one of the advantages you have in the in the UK, the NHS has many shortcomings, but one of the great advantages is this provision of universal access to all in a patient-centered way based on clinical need, and critically independent of the individual's ability to pay. Because trauma does not discriminate between rich and poor, and depending on what level of care you need, you will get it in the NHS because there is universal health coverage. And we may come to this later on in the discussion in terms of other innovative financial models, but I think this is one of the strengths of the NHS, universal health coverage for all. And interestingly for me, In the UK, people, even those who have private insurance, do not seek their trauma care outside of the NHS generally. And so, as we have all said in various ways, trauma and indeed emergency general surgery, which is another one of my passions, demands an integrated systems approach. And you can see in the slide here, I won't go into all of the details, but the London Major Trauma, Pan-London Major Trauma System is very much an integrated systems approach, right from commissioning through to the pre-hospital elements, including the major networks, and then the 4 major trauma centers and the 35 trauma units that feed into the 4 trauma centers now, of which the Royal London is one. And as I think it was Dr. Patanjali quite rightly said, you do not need a major trauma center on every doorstep, but you certainly need a pan-regional system which can treat, triage, and transfer appropriately. And why do we think this is all worthwhile? As again has been pointed out, we have tangible evidence now that in moving to such an integrated system across London for trauma, we have seen significant improvements in the outcomes for patients. So the paper was published a while ago. There are many other linked papers to this, which can be found in the bibliography, the references, but just very simply, the data shows that following the move to the system, which happened in 2010, there has been a statistically significant improvement in the odds ratio of survival over that time because of a movement to an integrated trauma systems approach. So clearly, the design of the system will be, as has been pointed out, require a consideration of the epidemiology of trauma in that region, the geography, and indeed the demographics of the population. For example, in London, what we are seeing is a movement away from road traffic collisions related type trauma to more penetrating injuries related to violence, and also a shift in the increase in the number of patients presenting with complex polytrauma related to falls related to the aging demographic. So a lot of the design principles will be informed by some of these things, and the design principles for Kerala will be unique to the Kerala population's needs in terms of emergency surgery, trauma surgery, and indeed emergency care provision. I mustn't forget that a significant part of emergency provision is medical too. And in terms of the design of systems, we have a level 1 to 3 approach. The Americans have a level 1 to 5, and it's clearly a case of patients being able to access wherever they interface with the emergency care provision system to access the right sort of care for that particular problem at the right level. And that includes appropriate resuscitation and triage and transfer where it's necessary. And therefore, we have to work out a way of providing even level 5 primary healthcare centers with an appropriate level of expertise, including things like ATLS training and so on, so that they can make the right decisions. So key to all of this is appropriate triage, appropriate treatment, and appropriate transfer as dictated by the clinical needs of the patient in a seamless way. And I've just put in a plug here for our Center for Trauma Sciences. For those of you who are involved in some of the strategic planning and design, as outlined by Dr. Patanjali in his talk, this is a useful resource for you in terms of a lot of the learning that has come from the NHS redesign of trauma, and particularly around the London trauma system. So I hope you may find some useful information and learning on there in more detail. And in a very simple sense, the way we have approached this at the Royal London, and indeed in terms of the London trauma system, is to think about it using a Don Obedient sort of conceptual model. What is our structure in terms of trying to determine what the framework of such a system, integrated system, ought to look like? And you see the evolution of that in terms of the way the London major trauma system has been designed. There are clearly things within the process that have to be looked at in this framework. And finally, what are the outcomes that matter to us for our patients and for our organizations and indeed for the population? And the point was well made about monitoring and implementation and the trauma audit and research network. Again, I've just signposted it there. The outputs from that have helped to drive a continuous quality improvement process for our trauma provision across the region. So that's been a very helpful thing, the National TAN database trauma audit and research network data. And just very briefly, useful ways of thinking about some of this stuff. Clearly, there is a pre-hospital and emergency department phase, where experts like Dr. Boy will have more to say than me, but this is an absolutely critical part of this. And interestingly, in my experience in Singapore, where I also was responsible for providing trauma surgery, I was able to see some of the differences in the quality or the standards of pre-hospital care provision and how that impacts on trauma outcomes in two different countries. So that's hugely important. If you want, you can call it D0. And the London Ambulance Service and the Helicopter Emergency Medical Service, they are exceptional service. And this is as much a key to our improved outcomes as any surgery that myself or my colleagues provide at the major trauma center. Secondly, there's a whole paradigm shift necessary in terms of understanding the resuscitative surgery approach, damage control surgery. Today, I will not get into some of the detail around that, but I think it requires a complete retraining in terms of the mindset of surgeons and other emergency trauma care providers around what needs to be done, just doing what is necessary, nothing that is unnecessary, and living to fight another day. So there's a whole training, I suspect, in terms of capacity development that will be necessary around damage control surgery. Critical care is obviously a key component, and then there is the restorative surgery, and that may be multiple returns to theater. How we structure our wards, we have a dedicated trauma ward now, how we provide rehabilitation, which will come into the conversation, after trauma team, which we have, and does some exceptional work around rehabilitation, end of life care provision, the prevention that was mentioned, and increasingly we are shifting our focus towards public health, violence prevention, and indeed a recognition that a lot of what feeds into the trauma input is actually trauma becomes an epiphenomenon for mental health issues. And so as a trauma service, we are gravitating towards various forms of prevention and engagement early on with the whole mental health challenge that we are facing. And I'm sure that's the same for other countries. So I won't get into this, but a lot of our process focus is about team working and human factors. And there's a whole systematic process that we have initiated to try and improve the way we run our processes and maintain continuous quality improvement for better patient care. Again, I have included some of the slides from this excellent WHO CERO document that Dr. Patanjali spoke to in some detail. And I'm just intrigued by some of the opportunities around smart financing and universal health coverage, which I'm sure will come into our discussions. And also, I think, particularly with COVID, certainly in the UK, and I'm sure across the world, we have seen how technology can help. And again, Dr. Patanjali spoke to this in some detail, but we're already seeing how we can have MTC supported decision-making for people out in the field. And I think that will be a critical part of how we make sure we have an integrated system that provides the right care at the right place for the right patient. And finally, why do we do all of this? Because this is the kind of result that you can achieve, not just because you have a major trauma center, but because you've had an integrated trauma care system. This gentleman in question has received exceptional care right from the moment they were picked up by the ambulance and helicopter emergency medical service. And this is a return to life in terms of quality of life for the patient and productivity gains for us as a state and as a system, which is why we all engage with this endeavor. So thank you very much for your time. I hope I've not overrun, and I thank you for your attention.
Thank you, Dr. Ajit, and it is an excellent presentation. And the floor is now open for any questions to Dr. Ajit. It is great learning from his presentation. I just have a question to Dr. Ajit, So you have written your trauma and emergency surgical service you provide. So if you see the context in India, now because of a lot of tunneling, a lot of surgical discipline, they have offshooted to various super specialization. The general surgeons are, are limited. The perforation, peritonitis, trauma, it actually, usually general surgeons are doing across the country. So what is the, future of this specialty, actually acute care surgery, which includes trauma in India?
So thank you, Dr. Boy. I mean, you have asked an excellent question. You've hit the nail on the head. We are facing the same problem here. And for me, the great paradox is, or the irony is that actually these are the patients who, if you treat well, because they're often young and otherwise fairly fit, if you treat a perforated duodenal ulcer or a bit of obstructed or strangulated gut, or indeed a young fit person who's had a road traffic collision and had trauma, you return them to a quality of life. The quality gain is huge if you treat these people. And yet we all are drifting into subspecialisms where we don't want to deliver that sort of care. So this is very much a challenge in the UK too. And what we are doing, in fact, the work I'm currently engaged in is precisely centered around creating an acute care cadre of surgeons. But we have to recognize that we cannot, we have to respect the people that we're asking to provide the job. So what we are trying to do is design a system in which they have a subspecialty interest too, and are supported in that as part of their emergency care provision. So for example, my subspecialty expertise is in HPB, although I've always had an interest in trauma. So what we're doing is ensuring that some of the acute care surgeons have a link to the hepatobiliary and pancreatic specialist provision and are trained in hot cholecystectomies, in the management of acute severe pancreatitis, and also get to participate in some of the cancer resections. So it's a kind of dual model with an emergency trauma emphasis, but with an allowance for specialist interest, which keeps their learning and their progression going. So I think there may be some sort of opportunity to do something similar within the general surgical ask that we will obviously have in the context of a state like Kerala or elsewhere in India.
I do agree with you, Dr. Ajit, and we are seeing in a tertiary care hospitals across India, actually these subset of people are often neglected. And actually patient die. Yeah. So before this super specialty were there, only where there were only general surgeons, all these patients were taken care of. The general surgeon can take care of, doing a splenectomy and doing bowel resection. So these are there and the core competencies were there. So, and also the training of the residents has gone down because most of the patients who come to tertiary hospitals in government sector are actually the top government hospitals shunted to other places. So that's why the training is also a huge issue. And creating only trauma surgeons in India, it is not sustainable in a country like us. You should have a broader specialty or of acute care surgery, or general surgeons learn about acute care surgery, which they have been doing since ages. Maybe a sustainable thing, and with even you get a job, you'll not be employed only as trauma surgeons. So that is the huge challenge which I think the next direction we should focus is any state who is actually building a policy should focus on this rather than creating an acute care surgery discipline which includes trauma rather than only focusing only on trauma. So that is what I feel, just like you have emergency medicine, a patient coming to the ER, and you have emergency medicine taking care of other things, you should have acute care surgeons who requires emergency operatives can take care of them and this thing. So these two, I think, are the key important pillars of our ER, I think. So what
just
is
very quickly in response, I think you're spot on. I'm very passionate about this. I think it is possible to design training systems that are meaningful, that are inspiring. And I think this is one of the considerations that should feed into the Apex Center considerations, because we are confronting this similar problem in the UK. You will not be surprised to hear And actually, we need these sort of surgeons to do that sort of work, because that's where you can make a real difference to outcomes for the population. So I completely agree with you on that. And I think it's possible to do so. Yeah.
Yes, yes, it is. Okay, thank you, Dr. Ajit, for an
Thank you.
excellent talk. And really, it was an eye-opener for all of us. So I think we can move on to the next speaker. Next speaker needs no introduction. Is Dr. Mohammad Asheel. He is the Executive Director of KSSM, Kerala. And he is also a very good friend, and we've been working since, I think, a decade. And Asheel has got, there are many accolades which Asheel has demonstrated. He is, I think, the key person, one of the key persons, the force behind the changes which you are seeing, in like a tsunami of change you are seeing in Kerala health sector. And I should not say that I should give, equal credit to him, with all the colleagues. I'm sure Srikant, Dr. Vishwanath is there. Welcome, Asheel, and stage is all yours. We are eager to listening from you.
Thank you very much, sir. Respected Boy, sir, Patanjali, sir, and Ajit, sir, and all dignitaries who are actually watching this webinar. So, presentation slides. Okay. So I will be briefly touching upon the trauma care system in the Kerala, what we have done till now and where we are heading to. Sorry. Which one? Sorry, some technical issues. Okay. Okay. Thank you. So now looking at the, maybe as all the speakers have said, trauma or injury may be one of the most understated epidemic of our times, because even taken together, HIV, AIDS, TB, malaria, if you look at the death per million, injuries contribute to around 1.7 times that of all these HIV, AIDS, TB, malaria in total. And the majority of them, like 24% of the injuries are related to road traffic injuries. And why do we have trauma care systems? Trauma care systems, there are enough studies to say that people with life-threatening but potentially treatable injuries are up to 6 times more likely to die in a state or nation with no organized trauma care system than in one with an organized resource trauma care system. So this is the odds of or having a better trauma care system. So developing trauma care system in the state, what we have done, a lot of exercise. It all began when I actually visited a trauma aid center and had a conversation with Sanjeev Boy sir, who actually led us to this path of setting a trauma care system. So we actually went to, we referred to around 61 national trauma care action plans which were available on internet, and reviewed around 17 major guidelines, primarily by WHO and our international organization. So then many other documents which was developed in our nation by various institutions and agencies and government. Based on that, there was a technical expert committee constituted, of which Sanjeev Boy sir was also, Sanjeev Boy sir, the key member of that, and a template on state action plan was prepared for the entire countries, the entire states or other states to work upon. So then we had to define a trauma care system, and the trauma care system, the best definition I think would be, it refers to all resources, tangible and intangible, that a defined geographic area has in place for the treatment of injured persons. Resources refer to human resource, physical infrastructure resources, administrative and legal factors, as well as the way in which they are utilized. So the role of trauma care system in the geographical area where is one of the primary factor which we need to actually consider when we talk about a trauma care system. And the role of trauma care system, of course, is to decrease mortality and the disability due to trauma and injuries. So trauma care system plan, which essentially must include reducing, as Rajan sir has said in the first slide, that in the first presentation, that in his introductory speech, he said that we will be focusing upon reducing the severity of disease and the prevention of injury. So that is something which is a very very important, because prevention is always better than cure. So, but when we come about a trauma care system per se, when we conceptualize a trauma care system, it should essentially have a pre-hospital care part, a hospital care part, a rehabilitation part, an information system connecting all these things, and administrative mechanism. And when we thought of when National Technical Expert Committee came out with a template, there were many components in that, and the first one of us, like understanding the vulnerability, or how do we actually know that what would be the resource to be put in? How do we actually know that how many ambulances should be there? How do we actually know that how many hospitals need to be strengthened at what level? So we need to identify our risk and our hazards, so that we need to have we worked on something called a risk matrix and hazard mapping. So for example, how it is done is that we take a state of Kerala and one district in that, for example, Ernakulam, we map the roads over there. That's based on what we call as shape files. So there are road shape files available with the department called Remote Sensing and Land Use Center. So we took the road network, we took the health institutions available there, mapped the health institution available there, overlapped both of these figures. We identified the major hospitals, reference hospitals over there. We identified the black spots, each black spots, as Rajan sir in his introductory speech said, we identified more than 300 black spots. And what we did was, we did something called a geospatial analysis. That's a vector-based geospatial analysis. There is network analysis, proximity-based analysis. This overall analysis we do in a software called ArcGIS, so that we can identify how many ambulances and how many hospitals and what and where is required. So we for example, when we can find that how many hospitals and where we need to where is this ambulance are located, all these things we can spot it on the map itself. And in addition to that, what we did was we looked into the level 3 hospitals, level 2 hospitals, identified the distance between them, and mapped the time taken for reaching these hospitals. And also the time, if we provide an ambulance at particular location, what would be the time taken for getting these to hospitals? All these things were worked out based on the network analysis and many other analysis which I have already mentioned. So when we identified, now we know that these much number of, then that's how the 315 numbers of ambulances came in. So that is based on, as Rajan sir said in his introductory speech, that is based on basically on a learned experience, and also based on a scientific model rather than an arbitrary number of 315. So we identified the 315 spots and established an ambulance network in that. So now looking at the hospital setup, how do we actually look at the resources which is required at hospitals? There are enough documents to say that. There is an operational guidelines by Government of India which has been prepared by JPNST, Jayaprakash Apex Trauma Center, which the institution headed by Sanjeev Boy sir, and based on the many documents including WHO guidelines for essential trauma care. These guidelines were worked on, and a template was prepared by which we can actually do the gap analysis. So gap analysis based on infrastructure, equipments, human resource were done, and administration and organization functions, including quality assurance, rules, etc., were also being looked into. So based on the gap analysis, as previous speakers has mentioned, we need to have a clear flow in the hospitals. So the triaging, the clinical decision unit, the ambulatory treatment, all these things need to be identified, the places need to be identified. Such gap analysis was done in around 86 hospitals, and what we have now is that we have a well-resourced ambulance network of Kani 108, and we have around 56 trauma hospitals with trauma care facilities already set in. and 9 of them is around is having the hospital, including medical colleges, and few of general hospitals having level 2 trauma care facility, and 2 is actually upgraded to a level 1 trauma care facility. So, and of course the Apex Trauma Care Center and the training center, which where we are actually standing now, and the trained staff. We have the lot of work has been done at various levels for training staff, and now as we have a Apex Trauma Training Center, which would be it would be the best in the probably best in the nation. So looking at the physical facilities, we need to actually upgrade the training human resource also here. So now. Then apart from that, as Patanjali sir said, rehabilitation is also a major part in that. So we have a traumatic spinal cord injury rehab center coming up, that is in a National Institute of Physical Medicine and Rehabilitation, and we'll be networking with all other institutions which is working on that. So that's what we have now. And we know that it's still a long way to go. And I must place on record the excellent leadership done by our Rajan sir and the team under our nodal officers of trauma care, Vishwanath sir and Srikant sir. They have doing excellent work in actually getting all these things ready, and I'm sure that when we have the best system to be reckoned upon, all these names would be remembered. So thank you very much, and it's a great opportunity, and it's best opportunity, or it's actually very much satisfying for me to presenting in a session where Sanjeev Boy sir, my teacher, is chairing the session. Thank you very much, sir, and thank you very much to all who are hearing that. Thank you.
Thank you, Dr. Ashil. If any questions are there to Dr. Ashil, please go ahead and ask. You can ask Dr. Ashil.
Can I come in, Dr. Bhoi? Dr. Patanjali here.
Please go ahead, sir.
Ashil, thank you very much, for bringing up the presentation. Very crisp. My question is about the ambulances, whether they're centrally managed. Of course, 108 is the number for the people in need or / patients to need it. But then how do you manage the ambulance fleet? Is it locally managed, centrally managed, or is a hybrid model? And what, in your opinion, the advice Kerala will give to other states in managing ambulances for these? Thank you.
What we have doing is we have centrally managed model where we have outsourced that entire thing to an agency, and that's doing it at a central point. So now, in the recent days, what we've done is that ambulance is taken for the COVID purpose also. So the central management is not really exclusively done, but we are doing it. To begin with, we have started as a centrally, completely exclusively centrally managed. But when the COVID came, and we need to actually decentralize in that. No, but for trauma care purpose, once we have done with the COVID, then it will again be centralized. So I'm sure that in order to say it as a model, it's a centralized model. So wherein we have a call center and we receive the calls, and the ambulance are deployed based on the GPS tracking system. And when we look at as advice on this or suggestion on this is that we in 2011-12 there was a panel under a National Health System Resource Center where I'm sure you are quite aware of that, sir. And we studied on various models of this ambulance networking. The CATS model in Delhi, the private-owned private model, the private-owned government-owned private run model. There are different models to say that. And when we were thinking of such a model, our choice was between private-owned and private run, and government is actually staying as a kind of a control. For example, that would be more cost effective, but the accountability was not so, because we had a few models like that in a few parts of the state. We had something called 102, where that was basically a model where in which private ambulance was enrolled in a system, and they were provided with training. A few equipments were installed in that, GPS equipments were installed in that, and to say that they have done a really good job, and it's a very cost-effective model also. But what was lacking in that is a kind of a accountability and a centralized model. So when we require triangulation, when we require a kind of a everyday monitoring, when we require a response time to keep a response time around 10 to 15 minutes, we need to have a more accountable system. That's why we have gone for purchasing the ambulances and setting a third party in installing. But at the same time, we have done something other to that also. The maintenance of this ambulance is also outsourced, because earlier we had an experience that this maintenance was actually the honor of with the government. So we had around a few ambulances went on repair, and the government procedure took a lot of time. So this maintenance plus running is outsourced now, as of now. So I think to look at various models, that is one of the, if you have enough resources, that would be one of the model. But to begin with, where there is no resource, I would suggest for a private run, at the same time as a government supported. Thank you, sir. Thank you, sir.
Well said, Ashil. But another question is, are these ambulances also connected to somebody who can advise a driver and the attendant there how to carry on something, some processes, or is just a transportation system?
No,
or
sir.
is it a transportation system come assistance from the long distance on cell phone or other methods?
Sir, it's a combination actually. When someone is having a trauma or someone is having an issue, there would be in the central call center, there is a medical advice team which actually be looking at where to take and how to take. That adds value to this, because sometimes what happens is that the patient may be unconscious. We may be having a private institutions which is very near to that. But so whether to take, so everyone's intention, if it is unconscious patient, you are supposed to take it to a government institution. But whether something is an emergency, that would be decided by the medical team who will be centrally placed. Thank you, sir. Thank you very much.
Thank you, Ashil. Thank you for the thing. We can move on to the next speaker and next session itself. I think we are going, slightly delayed on time, because many of the speakers have to also catch up their duties. So I would like to, ask the speakers to please cut short their presentations by 5 minutes. That will help us to wind up in time. So I request Dr. G.V. Ramana Rao, Medical Director, EMRI Hyderabad, to speak on pre-hospital training and transportation. So over to you, sir. Dr. G.V. Ramana Rao, sir.
Dr. Bhoi, exactly the way I had some issues, unless the rights are given,
Yes,
we
sir.
cannot hear Dr. Ramana and see him. Maybe there's a technical issue like I was having the first 2 minutes.
Yes, sir. Dr. Vishwanath, can you fix the issue, please? Dr. Ramana Rao?
Yes, sir. Now,
Yeah, please go ahead, sir.
so we'll go to the next session, and the second session is on the trauma transportation and treatment training. These are the key components of any planning of any trauma care system. And we have key dignitaries in this event: Dr. G.V. Ramana Rao, Dr.
Yeah.
Vinod Menon, and Dr. Sri Ravindran.
Am I audible to you? I'm Dr. G.V. Ramana Rao from Hyderabad, GVK EMRI. Am I audible to you, sir?
Yes.
Yes, Dr. Ramana.
So, yeah.
So,
Greetings from GVK EMRI, and thank you for giving us an opportunity to share. The focus of my talk would be on pre-hospital training and transport. I'll be using a deck of slides. My slides are to be seen. Are you able to see them? No?
Yes, sir. We are able to see you and also the presentation. No, we have.
Right. Yeah, good. You know, for a pre-hospital care, what is required is a unified 3-digit number, either it is 112 or 108. We also required a vehicle which can go to the instant, and there should be a trained people who are called paramedics or emergency medical technicians. So today I'll be speaking mostly on the training component of it. The person who receives the call is called emergency response officer, who sits in the state level command and control center. The ambulance driver is often referred as a pilot for his safe driving practices, but the pre-hospital care component is directly delivered by the emergency medical technician. And there is an online medical direction by the qualified doctor who is sitting at the center, and he is referred as a emergency response center physician. This is a point what Dr. Patanjali was referring to, and this is a model what we adopted. Coming to the pre-hospital training, I will be focusing mostly on the emergency medical technician. So we had an opportunity to initiate this pre-hospital care way back in 2005, starting from Hyderabad. Then it has become a public-private model. And we have taken either science graduates or people with some healthcare background. Training for the emergency medical technician is put into institutional, hospital, and ambulances phases. And we have been already using a lot of simulation learning so that it is addressing the patient safety concerns. In the context of trauma, all the emergency medical technicians, I'm talking about across the nation rather than confining to the Kerala model of pre-hospital care now, because it is taking a little deviation because of the COVID. So all our emergency medical technicians, as in the case of Tamil Nadu and Goa, they are also exposed to international trauma life support. It was otherwise called BTLS earlier. Now it is called ITLS. In addition to the American Heart Association BLS training program. They take about 450 hours of training spread in 6 weeks. And they will be assessed using the objectively structured clinical evaluation methods. So this is a brief about the EMT training program. And we became very conscious that what kind of skills they will have, because, and when we talk about the life support skills, we strongly believe that the skills are acquired at the individual level, and simulation environment is very, very conducive so that they can make enough practices. Taking into consideration, if these were the major skills an emergency medical technician in an ambulance should have with basic competencies, we have also gone into a little deep diving, and we have created how many times each EMT during the training program must practice the skills. It's a very detailed document, but nevertheless, the point here is the number of practices they need to do is very, very important. We also had an opportunity, because at the time the EMS or the pre-hospital care was not well established in this country. We have developed our own processes, textbooks, and then protocols also. We not only concentrated on the emergency medical technicians, but we have also concentrated on the ambulance drivers, and we call them the pilots. We have also realized in terms of training of the pre-hospital care personnel, education is important, but re-education is very, very important. So we have created an annual refresher training program for all the cadres, including the EMTs pilots. We have also realized that 28% of the situations require advanced life support care in the pre-hospital. So since 2008, with the collaboration of Stanford School of Medicine, we have created a 2-year advanced EMT course, and we used to call it PGPEC. For about 7-8 years, we were running with Stanford. Then it is affiliated to the local university of Hyderabad called Usmania. So some of the skills, this advanced EMTs, in the terms of the skills, in addition to the critical thinking, they will be able to do an endotracheal intubation, They will be able to really do some procedures which are all related to the shock management and procedures like cricothyroidotomy also. So this advanced program is taking 2 years, while the basic program is taking about 2 months in terms of duration. We have also realized in the training that there should be evidence-based protocols. So we had an opportunity to develop chief complaint-based protocol. So we use a process called assessment, analysis, and action. The assessment is done on scene or the moment the patient is brought into the ambulance by the EMT. And depending, we have to first finalize whether the patient is critical or not. In all critical cases, we have mandated that the emergency medical technician should seek the online medical direction of the qualified doctor who is sitting in the state level center. And this is one of the slides, a little crowded, but it talks about abdominal trauma. If there is an evisceration, they have to use a wet gauze, and then see to that that is protected. So to give you an idea about it. So we have identified about 55 such chief complaint-based protocols in the training program. Another important area of the pre-hospital care is destination determination. So our principle was condition of the patient, facilities at the receiving hospital, and the patient's choice we have taken into consideration. Very recently, we have also identified about 18 chief complaints and put them into subtypes of emergencies. And by asking 2 questions, we will be able to triage over phone whether it's a case of a critical or not. We also identified a lot of hospitals, particularly in the government sector, primary, secondary, and tertiary care level. And based on the chief complaint and the criticality, we were able to link it with the hospital. So right patient to the right hospital is what our journey has begun. And I'm sure we have started in the right direction, but there is a lot of maturity we need to establish in that. That is briefly about the EMT training program. As far as the transport is concerned, we are lucky that in Government of India, Ministry of Road Transport and Highways has identified standards for a basic life support and an advanced life support, as you would see in the National Ambulance Code. They have identified 4 types of ambulances, and the advanced life support has got some equipment like multi-parameter monitor, a ventilator, infusion pump, syringe pump. Now the equipment in the basic and advanced life support ambulances are standardized along with specifications, and anybody can access from this source. I just wanted to bring that in addition to these regular ambulances, we need some advanced life support ambulances, particularly for the interfacility transfers across the country. There are some riverine states where the boat ambulances are required. To navigate the traffic in crowded cities, we have also found the 2-wheeler first responder vehicles very important. In hilly terrains, we have started, particularly in Andhra Pradesh tribal areas, we have started 3-wheeler Sholay ambulances, otherwise called feeder ambulances. In Tamil Nadu and Goa, we found that before the patient is directly transferred to a longer distance, it is very important to carry out advanced stabilization, and we have innovatively identified emergency stabilization centers. While the regular ambulance is level 4 trauma care as per the national policy, I would use the emergency stabilization can be considered as level 3B trauma care. And positioning of the ambulance is very, very critical in terms of transportation, so that the GPS system would be able to identify the right location, what we call a dynamic location of the ambulances. With this simple processes of training and transport, this organization GVK, about 14,000 ambulances, 800 million we are able to reach, and every day we are responding to about 3,000 trauma cases and equal number of non-vehicular trauma cases also. We also identified that to develop a system, we need to identify community at the first dot, ambulance as a second dot, and the hospital as the third dot. So we made some attempts at the community level. One thing I want to bring it to the notice of the August audience today is active bleeding control, which is globally recognized as a stop the bleed. And we have been trying in one of the 2 national and state level corridors. 1,000 auto drivers and transport police were trained And so far in the last 1 year, about 150 cases were treated by those volunteers. And there were 30 cases where active bleeding was arrested by pressure bandage and application of tourniquet also. We have also realized that as per the bystander, they need to be trained bystander, and then we have started our first responders program. We have also realized that the pre-hospital trauma has to be registered, and we are a part of the Asian Trauma Pre-Hospital Registry, which is often referred as PATOS, and we have been doing for the last couple of years. So I just wanted to close my talk with blessings, what we are getting from the government of Kerala, because we have started these services 1 year back, and the Honorable Chief Minister was referring to this 108 ambulance services in Kerala as the first aid of the state. We were also blessed by Dr. Kalamji, who used to be our chairman emeritus, who always encouraged us that there's this business of saving lives, and saving one life at any given point of is the best thing which can happen. And our chairman, who gives us motivation to the joy of giving back. I had an opportunity to be part of this system representing India at World Health Organization some time back. And my closing comments and the way forward are highlighted here. In the training, we need to create basic and advanced EMT competencies within the country. And the drivers should also be trained very properly for safe driving. And they should also be trained on triaging and multi-casualty incident management. The doctors who need to be available for medical direction, I would also advise that in the post-graduation emergency medicine, there should be certain modules which I have had an opportunity to go through that, but they should be expanded so that they would also be becoming the leaders of the EMS or pre-hospital care in future. Our current policy of transportation of the emergency patient to the nearest appropriate hospital. With this, I just wanted to highlight on way forward. From the post-employment basic training, we should move on to university education, as is happening in other developed nations. We need to bring some consumables like hemostatic pads, injections like tranexamic acid. We need to start blood transfusion in the ambulance itself. We need to use the ultrasonography and consider this a model of emergency stabilization. We also require helicopter ambulance services. We need to really accept the technology in the form of electronic health records, and we can't have a homogeneous ambulance service dispatch. We need to have a criteria-based dispatch, and we should move from scoop and run to stay and stabilize. And finally, there should be a regionalization of health in the form of right patient has to be transferred to the right hospital. So that will be able to meet what has been envisaged in the National Health Policy, Sustainable Development Goal, and what is already clearly mentioned in the National Digital Health Mission. And we are supposed to have an accident insurance pan-India. Thank you so much. I'm going to stop here. Over to you, organizers. Thank you.
Thank you, Dr. Ramana Rao. It is a very excellent presentation. I do agree with you that as per WHO estimates, the premature death and disability can be reduced up to almost 54% by strengthening pre-hospital care and in-hospital care. And it is really a pride that the 108 service is doing excellently in our country over the decade and a half almost. So any questions from anybody? So if not, thank you, Dr. Ramana Rao, for an excellent presentation. So now I'll move on to Dr. Vinod Menon, who is actually spearheading the initiative in Kerala, the Trauma and Emergency Apex Center, the skill center, the simulation center. He has been spearheading, and we really appreciate your contribution back home to the country, sir. And Dr. Vinod is a consultant GI surgeon and director of West Midlands Surgical Training Center at the UK. And I invite him, it's an honor inviting him to deliver a lecture on key performance indicator in treatment and training. So just the prelude to his talk, just to inform you, because I'm chairing the national trauma policy in actually on sustainable, standard treatment guidelines, and also a part of key performance indicator, the national key performance indicator, which we have developed for our country, and it is going to roll up. So this, your talk will be very enlightening, sir, and maybe we can take your inputs. Sir, please go ahead, sir.
Thank you. Thank you very much, Dr. Boy. I hope you can hear me. And I'm just going to see if I could share my screen. Give me 1 second while I load this up. Can you see this, sir?
Yes, yes. Please go ahead, Dr. Vinod.
Yeah, thank you. Thank you very much, and for a very kind introduction. And I think this project is very dear to my heart, and I'm very grateful for all my colleagues back home to have made this a reality. And this is a very special day, and I'm sure the proceeds from this meeting would help us create a roadmap into the future. I've been asked to talk about the KPIs in treatment and training, and I'll try to go through them very swiftly because we're running short of time. We all know that trauma creates major impact, not just on mortality, but morbidity in people in their very productive decades of life. So it creates life-changing injuries, impact on livelihoods, therefore rehabilitation being most important. And of course, road traffic accidents are the most common cause, but we should not forget the others too. For example, in my home state of Kerala, everybody is aware of what happened with the fire disaster in 2016, the cyclone in 2017, the major floods in 2018, and everyday aspects like the road traffic accidents that we see. So we should have a broader vision just beyond simple trauma. In terms of designing key performance indicators, we need to look at the pre-hospital aspect, the hospital, post-hospital, which includes rehabilitation and trauma clinics, and also secondary prevention, which is back to the public health and community support. Access to CT scans. On the top left, you can see a major injury to the spleen. He has a ruptured diaphragm. There's an abdomen opened and an open abdomen. So we got access to theaters and access to interventional radiology. Interventional radiology is really a great advance in the field of medicine in the last 10, 20 years, and it's set to grow. So I've just thought I'll bring up the dashboard that's provided by the Trauma Audit and Research Network to my hospital, the University Hospital, Coventry and Warwickshire NHS Trust, as to what we collect in terms of key performance indicators. Of course, the demographics of data quality is so important. Everything that comes under demographics and how accurate our submission to the registry is. My good friend and colleague Ajit Abraham talked about the Trauma Audit and Research Network, and that's what we are part of. Evidence-based measures in terms of head injury, patients sustaining a head injury, how also mentioned about tranexamic acid and bleeding. That's also a major key aspect. You also look at system indicators in terms of consultant-led trauma teams, particularly in all aspects. So any number of system indicators and quality indicators that we can design, as Dr. Boy was saying, and it's not one size fits all, but we got to look at the nature of the injuries and the nature of the trauma. What about the delays in getting CT scans? And also, most importantly, as I said at the start, trauma affects people in their most productive years of life. So you got to think about rehabilitation. And I have to say that in the Western world, even rehabilitation is something that has not got the relevance and the importance. Everybody's keen to get the golden hour sorted, but what goes beyond, the patient living beyond the trauma should be part of key performance indicators. And this also builds a meaningful comparison by which centers and individual units could be compared. And as you can see here, this is a center I work in, and the number of cases and how we compare across our peers. And if we can get the key performance indicators and a database sorted and a registry, then this encourages healthy competition, and at the end, patient care is benefited. Moving on slightly to training, I think training's evolved over the years, like exactly as human beings have evolved from our four-legged predecessors to the thin men. And as you look now, obesity is so common. So this has changed. And the only thing we cannot resist and we find difficult to embrace is change. And here is where the training aspects have also changed. We heard from Dr. Ramana Rao about the newer initiatives for training. This is a very structured curriculum we have at the Advanced Trauma and Emergency Learning Center, going through the various training courses and the various aspects, which have all been clearly gone through by our scientific committee. But what I'm saying is this is something which is not set in stone, and we got to look at feedback and we got to see how we could make this even better. The Kerala University of Health Sciences is very keen to make this part of the curriculum of medical and nursing students, and we need to make a way to make this happen. I also need to touch base on mobile skills laboratories. Everybody does not need to travel to the main center. The regional training hubs, and they would think of connectivity, mannequins, technology, standardized training, encourage the concept of cascade trainer. Somebody who comes to get trained should train 10 others. This facilitates engagement and ownership and reduces travel, reduces accommodation costs. And you also identify the high flyers who are very important for sustainability. In the olden days, as a surgeon, I remember we had dinosaurs as our teachers. We never questioned them. We listened to them and we learned from them, but not in the best way. Times have moved on. And we heard the CEO of Tata Trust mention today about innovation, and Dr. Rajan Khobragade mentioned about this. And this is how the training has also changed. Surgical education has changed from reading and looking at models within anatomy labs to from the primitive operating theaters onto the new advanced laparoscopic and robotic theaters. Similarly, training has also evolved. Look at this. This is a trainer watching his trainee operate and a second trainee commenting or critiquing. And on the right, you can see simulation-based training, which is what the Honorable Chief Minister announced today about the next phase of our expansion, the Kerala Institute of Minimal Access Therapy. This will complement what we have established today. The West Midlands Surgical Training Center, I'm proud to be its director. This is a screenshot. We have 8 training stations where people come in, surgeons come in and have training on damage control surgery, right from head to toe. This is where the Honorable Health Minister visited about 3 years back, and the concept of today's project was conceived here. This is the course I was mentioning. They're doing emergency damage limitation surgery. Pandemic has provided with an opportunity to look at newer methods of training. We have set up video cameras and recording consoles in 5 of our operating theaters. And 2 weeks back, we ran this course of endoscopic FES surgery for ENT. This was broadcast to 16 nations around the world. So look at what training, the evolution of training in the last 5 or 10 years. And this is going to change even more. The feedback from the candidates and who come to our courses is so important. That's the only way training will improve and evolve. And these are just some feedback from some of the courses that we have run. There are some challenges. There are political, bureaucratic, I wouldn't say rivalry, but a bit of kind of distrust between professional groups. Who runs the administration? Who provides the leadership? And how do we sustain these? I think these are so important, and we need to have meaningful conversations to make this happen. I'll leave you with this one thought. As far as key performance indicators and in training and treatment are concerned, it is not rocket science. And we owe it to the people who have set this up for us today, the Government of Kerala, Tata Trust, and CIHS, and our educational partner. I remember the words of John D. Rockefeller, the famous philanthropist, who said, the key to success is to do the common tasks uncommonly well. And that way we can establish key performance indicators, establish the best of the best training in the world, and make this project a huge success. Thank you.
Thank you, Dr. Vinod, for this excellent talk, and it was really enlightening for all of us. And you also put out the right way, the map, how it can be sustainable, that, smaller provincial hospitals, they need not to come to Trivandrum to learn. There should be, local district hospital having small skill labs, and they can be trained, the ASHA workers, then village health guide, they can all go to the nearby facility and get trained. The same model has been replicated across the country. because that we have put as a policy from the Niti Aayog policy, because we are framing the policy right now.
Yes.
So that every district hospital is going to be having a skill lab with task trainers across the country. So this is there in the policy. Second thing is the government of India has already developed almost 120 skill labs across tertiary care hospitals, medical colleges in India, by central funding. So there is it is caught up the imagination of the nation that skill training is going to be the game changer, which it is visible on the ground. So there is a lot of focus on that. So it is really heartening, and it really we encourage, people like your expertise and other there in the panel who are there in the webinar today will utilize all the expertise, not only for Kerala, but to the whole country. So thank you for that. And I welcome Dr. Ravindran for the next talk. We're going to speak on state level action for sustainable development of trauma care. Dr. C. Ravindran is a trauma care consultant and additional professor of medical education. Dr. C. Ravindran, sir, please go ahead, sir. We can see your presentation slides. Yeah. And we can hear you also, sir. Please go ahead.
So good evening all. Thank you, Dr. Sanjeev Bhai, and nice to see Vinod. And I'm very happy to be amongst the light group for today. And my talk has been limited now because we have been hearing about the trauma care scenario in Kerala from Dr. Rajan Kopragade, and as well explained by Dr. Ashil. But I just wanted to concentrate on a few points as we are running short of time and where we are heading in this line. So with regards to the trauma care scenario all around the world, as we were talking about, and with the WHO's 2013 SDG, our target is to halve the number of trauma victims, and that is the present protocol where we all follow through. And the global trend has come down, as we are aware, in the well-developed countries, in UK and in US and the rest of the countries. But there is a slight upward trend in India and some of the developing nations. There are multiple reasons, and Dr. Sanjeev Bhai is an expert in commenting on that as well. I've been looking at the Kerala statistics and been working with a team of trauma nodal team. The trend in Kerala at the moment has stabilized a bit. And in the last 2 years, what we have found is the number of fatalities have come down. Even though the Kerala ranks number 5 among the number of road traffic accidents, the number of fatalities in Kerala on roads, I'm concentrating our time now on the road traffic accidents alone, has stabilized, or it is not increasing. And Kerala now it is around 10th or 11th in the national records. So as Ashil was talking about, the basic principle of evolving the trauma policy of Kerala happened around 6 years back. And if Dr. Sanjeev Bhai remember, in 2013, we hosted the Indo-USM Summit in Trichy, and you were the key person in that. And we had a lot of discussions on that with that time Kerala University of Health Science and Dr. Bharat Bhushan, the Chief Secretary of Kerala State at that point of time. And from that, the situation evolved. And as Ashil has passionately described, that we've developed this trauma care system, the policy system for Kerala. And the process was well established, or well spoken about by Ashil on the geospatial analysis, feasibility analysis, gap analysis, and quantification and budgeting to upgrade the system. So the process was a well-structured, well-systematized process by which we really identified which are the areas to concentrate based on different parameters. So I just wanted to highlight these 5 points alone at this point quickly on this, because we are running short of time. What we are concentrating, or what we concentrated on, and is one is a proper mitigation and hazard mapping. And that's what the Ashil established for identifying the 350 hotspots and positioning the ambulances in such a way to cut down the golden hour time. The second aspect I feel, which is very key, as Dr. Ram Reddy said, that is on the first responder capacity training, which is already established in one of the Mid-Kerala district of Cochin. And also the process is going on in Thrissur and Trivandrum, where the first responders in Kerala is usually the public personals, as well as the public, as well as the police and the fire service persons. So Kerala has got something unique in that we don't get too much of high velocity accidents or highway accidents. The accidents are more on the state highways, and the pattern of accidents also differs. I will come to that in a while. And then came the system renovation of the transportation. Again, that is well established, 108 ambulances positions at the geo-specific areas of 350 centers, well centrally connected. And nowadays they are taken into the COVID, but again, the district program support units of COVID is now monitoring and centrally controlling that system. Now, the third point or the fourth point, which was highlighted in the policy, was a system reorganization. When we talk about system organization, we are talking about organizing it's basically integrating the private, the public, and all the levels of trauma care, and restructuring the trauma care in such a way that, as highlighted by Vinod and also by Dr. Ramana and Dr. Sanjay Boy, we have got a systematic approach of where to take the patient and where to reach in the golden hour time. And of course, when the major trauma victims, they will require sustained care, as Vinod was telling. It is not just taking care in the first 30 minutes. And the last but most important point was about the training, trauma training and capacity building. And with the help and the guidance from all of us, all of you, we have established a PEC center in Trivandrum, and that will actually form the basis of the capacity building exercises all over the Kerala. So I want to analyze where we stand now with the limited time I have. We have done a reasonable mitigation and hazard mapping. The first responder training or the pre-hospital phase training of the basic training of the first responders are on the process in major district, but there is a big headway has to be created in this field. Transportation renovation has gone in, but I am again one person who also always vouch on establishing the level 1 centers in at least 3 zones in Kerala, that is one in Trivandrum, one in Mid-Kerala, either in Cochin or Thrissur, and one in Calicut, and linking these centers. An air ambulance is a call of an hour. I always used to talk on this. Second is the system reorganization. That is another point which is well on now, and I don't think we need to be worried about, because with the leadership of Rajan Kopragade sir, we have moved well ahead in the system reorganization in almost all areas. And the key areas is in the training. So the process is on the system reorganization in Kerala into the level. There are already 2 level 2 centers coming up, and there are 7 level 2 centers in the various districts, and there are 26 already established level 3 centers, which are well, I'm talking about the public sector, and then, but there are enough and more available in the private sector also. So the patients are able to be taken to these centers when a calamity occurs. Transportation system has been integrated, and that is all, as Ashil was telling, it just needs to be a little bit reorganization. And again, with the guidance of the core team, it is possible. The key areas which I again wanted to trust is, which we already told in the first 3 we have already covered, is on capacity building and simulation-based trauma training. I'm a key fan of simulation-based simulation-based training, and I was instrumental in involving at Kerala University of Health Sciences in developing the Center for Skill Development and Training. And I take Dr. Vinod's point on this. The Vinod was telling about having centers, regional centers of reasonable exercise excellence in having this training in different centers in Kerala. And with the amount of the potentials and the capacity train, and we can use all the gadgetries that is available to incorporate this training into other centers. And last but not the least is development of the trauma registry. That will be the key for formulating further plan. And I feel that Kerala is on the right path in developing with the team we have with you all on board. And I'm happy to be part of the team. And I thank Dr. Vishwanathan and Dr. Rajagopragade for allowing me to speak in this occasion. And the passion of skill training and with the development and integration of skill training is an area where I really would like to. And my little bit experience in UK and here shows that we are on the right path, but there are a lot of things to be structured in the coming years. And so with the help of all the dignitaries, allied luminaries who are advising on this, Kerala will be forming a well-developed policy in the near future. And that is what the future we are looking at. Thank you so much, Dr. Sanjeev Boy, for allowing me in the panel. I think that is about the policy the Kerala is having at this point of time. Thank you.
Thank you, Dr. Ravindran, for that excellent talk on state level action plan, which you reinforced many points as well. Thank you very much, sir. And we really had a good session on trauma training, transportation, and treatment, the gaps and remedies. So if you have any questions, so please go ahead and ask Dr. Ravindran.
Dr. Paul, could I say something? Yeah.
Please go ahead, sir. Please go ahead.
Fantastic talk, Dr. Ravindran, and I think the concepts are all there, and you have established a fantastic facility in Trichur, which is, I think it's, I think we are almost there. I think we just need to have a network of like-minded, innovative people. And in 10 years' time, with a lot of collaboration, we've got a fantastic faculty, we've got lots of people, within and outside the state, and people of Dr. Patanjali and Dr. Boy, and we got the right people. So it just needs, under Dr. Kopragade's guidance and support, and with the Honorable Health Minister, I think, we've got the right people. I don't want to miss anybody. We're on the right track. But thank you. Really enjoyed your presentation.
Thank you. Thank you.
Just one quick point from my side is, it was an external panel. We had a pre-hospital training and transportation. One of the key areas will be also implementing the key performance indicators in the pre-hospital care setting. And second, one comment is that there should be pre-hospital notification. We should be ensuring that there is pre-hospital notification by the GVK EMRI. That is key, the key information. The second thing is, when we are developing the state level action plan for trauma and emergency, beside this skill development, long-term development like establishing academic emergency medicine department, should be there in every medical schools of Kerala. And second, starting DNB program in emergency medicine in all district hospitals of Kerala. So that we are actually doing in other parts of the country. We have also recommended. And by 2022, every medical school should have MD emergency medicine program. So that is by mandate from also gadget notification from the government. So these are some of the comments which will also strengthen our resolve for good care at the end. So with this, I thank all the speakers in this session. Now let's move on to the next session. Again, I request all the speakers to be slightly brief because we are running short of time. Some of the international speakers have to go to their shifts because of this COVID times. So I'm sorry for that. So now I invite Mr. Srinath, who is the CEO of Tata Trust, and he's going to speak on the role of philanthropy. So Srinath ji, can you hear me, sir?
Yes, I can. Can you hear me?
Yeah. I can hear you, sir. Please go ahead.
Thank you. Thank you, Dr. Bol. Thank you. Good evening, friends. And I just want to say, having participated in the session today of the inauguration of the ATLC, it was, I think, a very proud moment for all of us who were present. because I seriously believe that what we've done today or what we've kicked off today is the start of a very interesting journey to completely change the paradigm of how we do emergency and trauma care in the country. So I personally have to say I was very touched by the entire ceremony and the entire process. And I think it was something that was really worthwhile that we did today. Let me just get my screen up. I'm having a bit of a problem getting my screen. Can somebody share my slides from? You've got a copy of my slides in the office. Is it possible to share it from there?
Dr. Srikanth, can you do that from that side? Dr. Srikanth?
Dr. Vish, yeah. I'm having, for some reason, some problem in being able to share my slides.
We'll just try, sir. Dr. Srikanth, are you there? Yes. Thank you, Dr. Srikanth.
Lovely. Thank you very much. Apologies for that. So what I'm going to try and do is cover, I think, a fairly broad subject in terms of what kind of role does philanthropy play in the middle of all of this? What do the different parts of the philanthropic ecosystem, the foundations, the trusts and so on, how do they play into this ecosystem, and what role can they play in moving forward the general process of healthcare, including innovations and so on? I'm going to do this anchoring it a little bit in how the Tata Trust themselves have evolved, given that we've been on this journey now for a little over 130 years. And I think we've obviously had to make many changes along the way as the requirements of society changed, and as we also started to learn how we could play an effective and a good role in kind of making change happen in the social sector. Next page, please. Just to give you a context of who we are, we've been operating as a trust since the 1890s. We've been in operation for over 130 years, and our focus initially was to be a provider of alleviation for individual issues, people who had medical problems, people who needed money for education. We were largely focused on the problems of individuals, but from then we've come a long way. We've evolved. Initially, we were looking at being a grant-making organization, supporting the efforts of other organizations, NGOs, foundations, and so on in a multiplicity of areas. The big areas of focus for us being healthcare, nutrition, education, rural upliftment, migration, and water and sanitation, and so on. So we've been focused on multi-thematic areas across the country. We work in probably about 150, 160 districts across the country at this point in time. And clearly, as the requirements of society have evolved, as the changes have happened, as more and more people have come into the ecosystem, as government policy has also changed, new schemes have come in, we've also had to evolve the way we have treated or the way we have approached the issues of society. Next page, please. Specifically on healthcare, since that is a subject of interest today, the way we've set our vision is to create a healthy India by enabling access to equitable, affordable, quality and sustainable healthcare and to the underserved. I think there are some fairly important points in there in terms of saying equitable, affordable, quality, sustainable healthcare, and particularly focused on the underserved. We obviously have a very specific focus on both women and children as part of our programs. Next page, please. What is also interesting is a lot of this is things that we've been doing for a fairly long period of time. I've just kind of thrown up some examples for you to look at of some of the innovations that were kicked off by the trust going back as far back as 1912. Some of the big ones, some of the ones that you may be familiar with, is setting up of the Tata Memorial Cancer Hospital in 1941. But we've also done multiple interventions across system building, institution building, capability creation, technology innovation, if you go back to some of the examples that we will talk about as we go along. So the trusts have had a long history of philanthropy in the country, like I said, going back almost 130 years. And healthcare has been one of our major focus areas. Next, please. I think it's important to spend a little bit of time on this in terms of what has driven the way we've approached the sector. And I think it's important to kind of be very clear that the center of all that we do has to be the community. And I think that's something that that it's important that we not lose sight of. It's very easy to say, I have a solution, I'm looking for a problem to apply my solution to. Clearly, we need to work outwards from what the community requires us to be doing, what the community requires specifically at a point in time. Be solution driven, foster collaboration. It's very clear that no single institution, whether it be a foundation or government or private sector or even CSR, has the requisite skill, has the requisite reach, has the requisite ability on its own to be able to completely address a solution or a problem, to bring lasting change, to bring impactful change, to bring sustainable change. So clearly, working with partners is a given as far as the sector is concerned, and that is something we take quite seriously in all that we do. And partnership is not just about raising money from other people. Partnership is also leveraging capability that other people may bring. Somebody has a technology capability, somebody has an IT or a data capability, somebody has a last mile reach capability. So there's a whole bunch of complementary capabilities that typically we have to bring to bear in addressing a specific issue. And the example of today, clearly there's been a consortium of people who have come together to make the center possible. It's the government of Kerala who provided the impetus, who provided the drive. It's people like us who clearly have an interest in healthcare and supporting healthcare innovation in the country. People like the CIHS team who helped us really put all this together. So multiple people typically bring together capabilities, bring together knowledge, skills, competences in a complementary fashion to make things happen. Focus on innovation. I'll talk a little bit about a couple of examples of some of the stuff that we've tried to do specifically on innovation, because I think we've tried to chart something quite different from typically what other foundations have done. Seek to achieve impact at scale. The mantra, if I could call it that, for what we've been doing for many years now, is to look at the fact that our programs have to have impact at scale, and also over a period of time, the programs have to be sustainable as well. And that's really the longer term vision that we have in terms of how we run our program. And now increasingly, we're looking at technology fuel solutions, and I've got a couple of examples that we can talk about. Next page, please. The interesting thing in terms of where our approach to philanthropy has been, is that we're looking at pretty much an end-to-end value chain, starting from a simple identification of a problem all the way through to creating a sustainable solution, which even leads us to exit a particular intervention. One of the things that we look to do, we believe a program is successful when not only have we identified the kind of issues that a particular community or a group of people is facing, but we're able to bring to bear the necessary capability to put together a solution. But more importantly, the solution that we create does not create that system to be dependent on us, but leaves it independent, leaves it in a manner that it is able to function and sustain itself even after we exit. So the sustainability aspect of how we create these programs is extremely important. What is also important to keep in mind is the intervention no longer is an isolated intervention. The intervention in many cases tends to be symptomatic of larger issues. There are regulatory issues, there are policy issues, there are issues of how the social market tends to function. For example, access to market for products of many of the people becomes an important issue for us to address. So it's going beyond the simple value chain, saying starting from identifying a problem to creating a solution and creating a sustainable solution and being able to exit. It also requires more and more. It requires people to come together to create solutions which are long lasting and which have impact across multiple areas and make permanent changes in systems, changes in the environment, changes in the regulation, changes in the way certain policies operate, changes in the way state and central governments look at issues, all of which are necessary to create a sustainable impact on what we're trying to do. Next page, please. Interestingly, if you look at where are the areas that we typically tend to play, again, this has been talked about and I don't need to explain this to this audience, but the role that we tend to look at cuts across pretty much all aspects of the value chain of healthcare, starting from simple awareness to what is the kind of awareness that people have of the kind of diseases that are out there and what does it take to treat them. I'll give you one example. Our cancer program is clearly hinged on creating awareness. One of the things that we found is the general awareness of cancer, the general awareness of how cancer should be treated, how treatable cancer is pretty low in the country. And therefore people tend not to go out there and identify or not to realize when they have a problem and go out and get themselves treated. So awareness is a huge issue in terms of making people aware of, one, what are the kind of issues that they face medically, but more importantly, what kind of avenues and remedies are available to them in the ecosystem. The availability of multiple things, availability of infrastructure, availability of capability, availability of human resources. So we have roles that we have played, and I'll give you some examples of the kind of work that we've done in that space as well. Accessibility is, you have great facilities, you have great people, but for whatever reason, it's not available to many people to use. So again, I'll give you the example of what we're doing on cancer care. One of the key elements that we're trying to address, and we're building about 20 odd hospitals across the country, of which we'll probably end up operating between about 10 or 15 of them. And the real model is to say that part of the problem on cancer care today is that people have to travel great distances to get the kind of quality care that they need. And therefore, it's important for us to take that care closer to the people in whatever form. We're also running programs with some of the state governments today in terms of working them develop their urban health centers to a point where you no longer need to go to a tertiary center for simple issues. You're able to go to a primary health center and get a lot of your basic needs taken care of. So there's multiple things that we can do on the accessibility side. And of course, the affordability story in terms of how do you bring out products to market which are cheaper? How do you bring out services to market which are cheaper? How do you come up with government schemes? How do you come up with insurance support? How do you come up with different ways to make services more affordable to people? And all of this, again, whole bunch of issues around health education, treatment provision, and technology application. The next one, please. Yeah, just some examples, and I'll leave you to read them. I'm not going to walk through each of them. I just want to talk about some of the programs that we're doing and how they play into what I talked about in terms of awareness, availability, accessibility, and affordability. And one example I gave you was the cancer program, where the basic tenet is that one, people get to know about cancer very late in their lives. Second, people have to travel great distances to get treatment for cancer, and that becomes extremely affordable, extremely expensive for them. And in many cases, because they happen to be out of circulation, they also have a negative impact on their ability to earn during that period. And the economic hardship in many cases causes people not to pursue certain forms of treatment. So we've had that in many of our institutions. We've seen that in some of the institutions before. So the way we've tried to address that is to try and create a network of cancer hospitals, basically architected on simple daycare centers going all the way up to full sophisticated institutions with research and development, research and capability as well. And for example, in the state of Assam, we're building 10 hospitals at this point in time, all of which will come live during the course of this year. And we have one L1 and multiple L2s and L3 centers. And then we are supplementing that with outreach programs to be able to go out and talk to the public and to make them understand what kind of issues they are, to do early screening. For example, in certain places, we've noticed that tobacco abuse tends to lead to a prevalence of a certain type of cancer. And therefore, the more we are able to go out into the field, the more we're able to actually do early screening, the more we're able to bring people into the health system that much earlier for us to be able to work on specific issues that they have. So that's one example of a program that we've been running. The other example I'd like to give you is we started a fund called the India Health Fund. One of the ideas that Mr. Tata had several years ago was that it's not enough for us to be just doing interventions on the ground. It's also important for us to look at what's happening in the incubation space, what's happening on the innovation side as well. So we have supported multiple programs on both incubation as well as innovation. And India Health Fund is one of our specific interventions on the health side. Basically, India Health Fund is not an incubation company, but an investor in technologies. For example, they've invested in companies who have the capability to, one company that they've invested in, for example, is the MolBio company, which came up with a particular kind of test intended originally, I think, at tuberculosis, but then which got broad-based to COVID. And they're one of the qualified and approved COVID tests in the country today. They've supported a company which also looking at how you can digitally read X-rays to get at least the early screening done, to be able to replicate a level of skill, for example, that the technician would bring to analyzing an X-ray. We've also invested in, to some extent, genetic research in terms of, is that an avenue for us in terms of how we can eradicate malaria by trying to address some different parts of the supply chain, different parts of the value chain or the life cycle of a mosquito. For example, can you catch a mosquito and prevent it from reproducing? Can you catch a particular breed of mosquito which is particularly bad for malaria and prevent it from reproducing? Can you find a way to reduce the drug resistance that mosquitoes seem to have built to pesticides over a period of years? So again, we believe that it's not just important to run the programs that we do, but it's also important to support innovation that happens out there. And there's a sheer amount of innovation that's happening more and more in the world today. And to be able to bring those capabilities to bear on the problems that we're trying to solve. We've also done this in other ways. We've also partnered with universities in many instances, both domestic as well as international. And there also we've gone and looked for the best capability in a particular area and said, look, this is a problem that's particularly acute in our country, particularly important to us. And we'd like to see if we can work with you to find a way to find solutions, come up with interventions that are able to alleviate some of the issues on that. So not only is the approach that we've taken finding solutions to specific problems, but also anticipating where the future is, anticipating what new technologies are coming down the corner, anticipating, for example, what new digital capabilities are available. So when you're dealing with a large number of patients like we are doing in a couple of programs in Uttar Pradesh, in Madhya Pradesh, we're also helping set up a basic patient record system to be able to track and enroll patients at least at the entry level, with the intention at some point in time that this will become important patient history for us to be able to take into maybe into phase 2 and phase 3, where we'll be able to at some point in time hopefully manage the life cycle of a patient and not just manage the specific symptoms and issues that we face. So that's one more page, please. I just got one more page with some examples of some of the work we do. Next page. Yeah. So again, like I said, multiple interventions. A lot of them will be anchored in the basic principles I spoke about, anchored in the community, focused around how we can create awareness, focused around how we can create availability, focused around how we can improve the accessibility of healthcare facilities to people, and not the least, how to make the whole value chain much more affordable to the patient. Yeah, one more page, please. So just to recap, kind of tie it all together and take it back to where we are to basically create a healthy India. And the key words are equitable, affordable, quality, and sustainable healthcare, particularly to the underserved. So I thank you all for your patience. I thank you all for giving me this opportunity to speak to you today. I'm quite happy to take any questions. Thank you, sir. Doctor, back to you.
Thank you, Srinath ji, for this very excellent talk. Any questions to Srinath ji? So if not, thank you very much, sir. Anybody? Yes, please go ahead.
Somaraju from Hyderabad.
Yeah, just a brief question, sir.
You conducted, you said so well, sir. I probably need not talk, but then I must tell you the greatness and the excellence with which you conducted yourself in Tata Trust, and so many areas you helped. I would say Tatas are equivalent to cancer. They are spreading like cancer. Goodwill, I mean.
Very kind of you, sir. Thank you very much. It really means a lot coming from a person like you, sir. Thank you very much.
Thank you, sir. Thank you for this talk. Now we'll move on to Dr. B. Somaraju, sir. He is the founder, CIHS, and senior cardiologist at a place at Hyderabad. Sir will speak on the role of private players in capacity building and training. Over to you, sir. So, welcome, and it's a pleasure and honor to invite you, sir, this webinar.
Good evening to all of you, the distinguished people from different walks of life, and I'll make it as brief as possible. I am asked to address the issue of why public-private partnership in healthcare. And I would say problems in the world are classified as simple, compound, complex, and unsolvable. But the problem of healthcare, as Mr. Srinath pointed out, is even more complex. It is called a wicked problem. This wicked problem is such that none of us can do it alone. It is neither doctors or nurses alone, or private sector or public sector. None of us can do this alone. We will have to bring in all the resources available in society to make it happen. Not only different partnerships of public and private you are talking about, the health and disease change in such a way, even present medical education of only biological science and chemical science is no longer able to take care of it. We need all the other areas like information technology, say physics, chemistry, molecular biology, and leadership and teamwork, everything. And none of us are capable of doing this ourselves. That's the reason why the need for partnership. And as some of these Mr. Srinath pointed out, the Institute of Medicine in US came out with a document saying to err is human. They found the healthcare we give is supposed to be safe, effective, patient-centered, timely, efficient, equitable, and sustainable. But they found it is not happening. And many of us believed that we were doing all this well, but it was not true. And in US hospitals, more than 1 lakh of people, the best hospital in the US, people die of medical errors. And it is said, it is not me, again, quoting, say, Institute of Medicine, I'll try to be brief. If banking were like healthcare, automated teller machines and transactions would take days or longer, result unavailable to misplaced records. And home building is like healthcare, it won't do well. If shopping were healthcare, it would be very bad. If airline travel were like healthcare, there will be daily accidents. And automobile industry, Tatas know it better. And all of them do better than what we are doing in healthcare. I accept it. I'll skip some slides in the interest of time. But this requires that we need to transform ourselves. Transforming ourselves is not possible unless the way we educate ourselves. The education in each of the areas like healthcare, they are the same thing as the systems we are working on. Somebody was suggesting that the University of Health Sciences in Hyderabad, Andhra Pradesh and Telangana and many other states. And Tatas have cancer hospitals. I'll want to add and only leave it there telling that specialties healthcare and organ-based healthcare specialization should end, because cancer is too complex to be left alone to one specialty today. And similar thing is applicable to me as a cardiologist. I would say we harm a lot of patients if we only take care of cardiac patients, and we'll be not be able to take care of rest of the problems and rest of the systems. A lot of harm will be done. I won't elaborate on this much today, except telling you that multi-speciality and multi-generalizing specialists are the requirements of the day. And this generalizing specialist is not doctors and nurses alone. People from different walks of life and technologists, information technology and management specialists, and basics of economy and molecular biology and genetics, all these things you have to bring together into medicine. Social sciences, for example, Tatas have social science institute also, I am aware of. All these people have to come together to do something. University of Health Sciences, to me, sorry to be using this word, it is an oxymoron. It is too inadequate to be able to address the present requirements of healthcare. I will say public institutions, private institutions, not-for-profit, and plural organizations who do not belong to any category of the above, they need to come together and make this happen. I'll leave it here because of the shortage of time. Maybe some other time I'll share some of the controversial things I said about the need for non-specialized generalizing institutions. The generalizing specialist is the need of the day. Thank you.
Thank you, Dr. Somaraju, sir, for his perspective and very wise words. And now we'll move on to Dr. John Panikkar. Dr. John Panikkar is a state coordinator and Trauma Rescue Initiative, IMA. So he'll speak on the role of public-private partnership. Dr. John Panikkar.
Yes. Thank you, Dr. Sanjeev, the moderator, all dear faculty and the organizers and friends. At first, I want to thank you all for giving me this opportunity to share my ideas and views on this particular subject. It was in 2017, 4 years back. There was a very sad incident of an accident, and the victim was one Murugan, one Mr. Murugan, about 60 kilometers from Trivandrum, he met with an accident in the national highway. And he was immediately taken to a nearby hospital, stabilized, ventilated, and put in an ambulance. And the doctor gave a letter to Trivandrum Medical College, which is the apex hospital here, for a trauma care. But unfortunately, this ambulance driver took the patient to another 4 or 5 hospitals where there were no such facilities, including one medical college. And in fact, this particular patient was in the road for nearly 6 to 7 hours. And finally, he was taken inside the medical college and, of course, expired. So this was received a huge media attention. And at that time, everybody was blaming on the doctors why the patient was not taken and given the treatment and like that. But and in fact, a few doctors were made scapegoat also. But at that time, I was the president of the Trivandrum Indian Medical Association, which is one of the biggest IMA branches in India. Around 4,500 doctors are there in that branch. And we then discussed we made a seminar, we discussed everything, and we thought of networking the ambulances. And that initiative is otherwise Trauma Rescue Initiative, which is a product of Indian Medical Association. We had discussion with the Kerala State Police. So it's a joint program of Kerala State Police and Indian Medical Association, Trivandrum. Fortunately, one of my close friends, who was a former president of the Indian Doctors Association in America, API, and also he was the president of the Kerala Medical Graduates in USA. He sponsored all the expenses of the project, and we networked around 2,000 ambulances. In fact, Kerala, we have a private ambulances, not belonging to any hospital or to the government, and that is around 3,000 to 3,500. We networked around, at that time, we networked around 2,000 ambulances and gave training to all the ambulance crew at that time. And as mentioned by Dr. Ashil, the same method, we did it 4 or 5 years back. And by GPS, we networked all the these ambulances, and then we have specific staff in the police control room of Trivandrum. And from there, this project is working with a common number of 9188 all over the Kerala. We have around at least 100 to 150 ambulances in every district. So if there is a call to this particular number, immediately we will summon the nearest ambulance. We can find out the nearest ambulances, and then we will summon that ambulance and ask the ambulance to take the patient to a particular hospital. We will inform the hospital prior to that such a patient is coming. So that is the way we are working now. And in the last 4 years, nearly 3,000 rescues were done. Actually, so that was my experience, and I am the state coordinator for that. Now, the challenges, excuse me, can I have the slide? Excuse me, hello?
It's already there.
Hello?
On the screen. You can go ahead.
It is there. Okay.
Go ahead, please go ahead.
Okay. Just actually, I cannot see it. It is in the screen. The slide, first slide. Hello, Vishwanathan, Dr. Vishwanathan. Hello.
Yeah, Dr. Vishwanath, Dr. Srikanth, please help. Please have Dr. Panikar.
Dr. Vishwanathan. Hello.
Can you see your slide, sir? Dr. John.
Hello.
Can you see your slide?
Can you see the slide? I can't.
Yeah, we can see your slide.
Yeah. Okay. So, can I have the second slide? That is, excuse me. can I have the second slide? Hello, anybody is in the?
Yeah.
The second slide is
you,
on. Yeah. So the challenges right now are in four stages. One is the definitely. Excuse me, sir. So unfortunately, I cannot see my slide. Okay. Dr. Vishwanathan is there. Vishwanathan, are you in the stage? Or Shrikant?
Yeah, they're there. Actually, Dr. Shrikant, Dr. Vishwanath, Dr. Panikar wants some help.
Okay. Just anyhow, I will proceed with that. Sorry for the trouble. So, see, we have the challenges are mainly the prevention of accidents. Because when I go through the statistics, in 2019, in United Kingdom, the accidents were around 27,800 major accidents, and out of which the fatality was only 1,748. The vehicular density there is around 40 million, whereas in Kerala, in 2019, we had around 35,000 accidents, and the deaths were 4,200, and our vehicular density is only 11 million. So that is the difference. So definitely there is a scope for preventing the accidents, definitely. And in fact, this is one thing which is we are not giving proper priority here. So that we have to take care, definitely. Number two is safe transportation of the victims, which as mentioned, that we have the 108 ambulances of 350. At the same time, in addition, we have this 2,500 private ambulances operated and monitored by Kerala Police and Indian Medical Association. Then the third one is the medical management. That is a lot of information has come up, and probably, and the thing is, especially in the medical management, the trauma hospital in Kerala, we have around 37 to 40 government trauma centers already identified. And out of the, in total, we have Kerala, 30 teaching medical colleges are also here, of which 20 are well equipped to handle any level of trauma. Then, whereas in private sector, we have more than 60 tertiary centers in the private sector right now. And again, we have another 100 to 120 secondary specialty hospital we have identified, and 300 primary specialty hospitals also are there. So that means more than 2/3, or 2 to 3 times private hospitals are here to cater to the trauma patients. Now, coming back to the rehabilitation, this is one thing which we have been ignored so far. And generally, Kerala has very few centers of rehabilitation. And here, definitely the private institution can fill the gap with the government support. And definitely, there are a lot of NGOs are here, like Rotary, Lions, and these are there. So it is always better to have a joint venture. Like we have an excellent model in Kerala of PPP. The present training center by Tata is the best example for that. We have the Cochin Airport. Again, it's a PPP model. In medical college, we have the Alumni Association. We are doing a lot of things. I happen to be the president of the Trivandrum Medical Alumni Association also. Then, so that way, I think definitely we have to improve all the 4 sectors of the trauma care. That is prevention, training, then transportation, safe transportation, medical management, as well as in the rehabilitation. Now, how to go forward? What the Indian Medical Association would suggest is there has to be a Apex Kerala trauma care. Sorry, Apex Kerala Trauma Care Authority as PPP model, in which there has to be the government officials. We should have, see, the problem here is, apart from the medical management, the prevention, the everything, also other department also has to come up, like PWD, Public Works Department, the police department, transport department, all this has to come up. So we need to have a coordinating body, and we would suggest for a Kerala Apex Trauma Care Authority with the public and private participation. This can coordinate various activities and to advise the government, and also to advise government. And the one thing is, this authority can probably raise funds much more easier than directly by the government. And also what we would suggest is, Kerala, especially certain districts are in the hilly areas. And for example, the Idiki, even if generally the Idiki district and the Wayanad district, they don't have good trauma care centers. So to take a patient from there to Kochi, which is the nearest main city, it will take minimum 3 to 4 hours. How many ambulances are there? So what we would suggest is, there has to be a exclusive trauma center for every district, because considering the population, we have around 14 districts, and it won't be very difficult to establish such a thing. Again, that can be with the public-private participation. Now, Indian Medical Association Kerala, we have around 38,000 members of doctors here. And probably I would mention about the role IMA can play here. A lot of specialists are now coming up in Kerala, and the Indian Medical Association can definitely join the training program. And also, as I mentioned, again, we can have a better networking of the ambulances. One shortfall in the present ambulance setup is, the same ambulance is transporting COVID patient, then taking a trauma patient, then taking a dead body. So that has to be classified, and probably accreditation should be given to different things. And also, then if the public-private participation is there for the networking of the ambulances, the cost can be drastically cut down. What I understand is, for a 108 ambulance, the cost per kilometer is around 150 to 160 rupees, whereas what we provide is around 20 rupees per kilometer. Even some of the cases we give free, because the payment comes from the fund we receive from Dr. Narendra Umar. And then the IMA can also give enough human resources, because a lot of doctors are there under the Indian Medical Association in Kerala. As I mentioned, around 35 to 40,000 members are here in IMA. Then another thing is, probably we can help in the accreditation process also of the hospital as well as of the ambulance. So these are the things I had to share with you. I take this opportunity. I am extremely sorry that I couldn't see the slides I given to the technical people. So thank you very much. I am extremely thankful for the patient hearing, and also thankful to Dr. Vishwanathan and Srikanth, Vinod Menon, and also Mr. Srinath of Tata Sons and all. Thank you very much. Thank you.
Yeah, thank you, Dr. Panikkar. And it was nice to hear your perspective. And we all reiterate that we have to improve the trauma services with the both help of public-private partnership. And you very rightly pointed out the locations of various ambulance stakeholders in the state. And you also pointed out very nicely, which I also agree with you, then we need to do aggregation of these ambulance services with a unified number. So what is called as
Dr. Sanjeev, one thing I want to mention is, it is true that they have identified 350 sports and all these things. But the thing is, there will be multiple fatalities sometimes. Multiple injuries, persons will be injured. In that situation, it is not enough to have one ambulance there. That is the need for, we should, for example, a bus accident. It's a very, very common. Kerala, we have a very excellent public transport, mainly by road buses. So we have seen bus accidents, and in our experience, in our this trauma rescue initiative, many times we had to summon 7 to 10 ambulances at a time. So that thing, probably we need the private ambulance also. But the only thing is we have to classify them. We have to give accreditation and training, proper training to all of them. That's
Yeah. Thank you for your perspective, sir. And now let's move into the last session of the day, and that is on capacity building and training. And we have great speakers lined up, and we have luminaries from different parts of the world. And this is a very passionate subject, which actually means business, and she's the change in the ground. And I invite, Dr. Sagar Galvankar, who is actually the Director of Research, Florida State University, and Executive Director for World Academic Council for Emergency Medicine. And he's also spearheaded the development of emergency medicine in this country, and have a almost decade and a half association with Dr. Sagar. He's a close friend, and also, worked with us tirelessly, and right now also is tirelessly working towards development of or improving both emergency and trauma services in this country. He's an international expert as well. And may I welcome Dr. Sagar Galvankar for delivering his speech on capacity building and training. Over to you, Dr. Sagar.
Am I audible? Am I audible?
Yes, Dr. Sagar, you're audible.
Enna sarvakinna ella manika vyaktigo namaskaram. Ella Asham Sakulam from Tampa Bay Malayali Association. The topic for my talk today is capacity building and training in emergency medicine. This is our Tampa Bay Malayali Association, who send you all their greetings and blessings from Florida. I would like to start my talk by dedicating my submissions to the INDOCM mission, which has been in India for the last 15 years, tirelessly trying to develop academic emergency medicine in India. And why were we more involved in academic emergency medicine and not infrastructural development is what my talk is all about. The leading associations for representing emergency medicine and care in India are the Emergency Medicine Association of India, the Academic College of Emergency Experts in India, and the Academy for Clinical Emergency Nursing in India, which all are a part of the INDOCM mission to develop academic emergency medicine and excellence in India. The objectives of my talk is: what is the definition of capacity building in emergency medicine? What are the operations, roles and responsibilities, maintaining quality via training? And then I can take some questions. My background: why am I here to speak to you? Why am I competent to speak to you? It is because I'm trained in medicine, background in internal medicine in India. I have got my board certification and residency training in emergency medicine in the United States. Please be aware that having a F with something in USA like FACP or something is not a degree. It is a membership of an association. It is not a significance of training in the United States. You can pay and get your F. Public health and policy training in public health in USA. Operations management with a business administration degree in the United States. And I'm trained in India and the United States, and I have worked in India. So I'm not sitting in an ivory tower and saying what is to be done, but I have firsthand experience for nearly 1.5 decades of developing emergency medicine in India, academic emergency medicine policies in India, and that's been my career as an academician and a systems architect. And above all, I'm a proud Indian citizen. I start my talk by this fundamental fact: systematically trained, skilled emergency provider teams staffing emergency departments is fundamental to success of secondary prevention. If you don't have this fact clear, any system we build is a failed system. Another fundamental fact sheet, which you all have to be worried and be aware, is very important to make an impact. First of all, emergency medicine is not medical emergencies, and it's definitely not critical care. That is a big misnomer, which will lead to the failure of any system you develop. Secondly, emergency medicine is a surgical discipline. It is not a medical discipline. Being ATLS certified does not make one a trauma surgeon. Being ACLS certified does not make you an emergency medicine specialist. Emergency department caters to patients from neonate to geriatrics, includes pregnant women with any pathology, surgical or medical, or even social pathology, including psychiatric, suicides, rape, abuse, and violence, a single patient, or even a mass casualty. And the emergency medicine specialist is trained to handle each one of them. Emergency medicine began as a surgical discipline in every part of the globe and evolved to be its own specialty. MD and DNB are the only two recognized qualifications in India as regards emergency medicine. Trauma has individual specializations after you complete your MS, MCH. Surgery, trauma, orthopedic trauma, pediatric trauma, vascular trauma, and neurosurgical trauma are super subspecialties. And this current move in India to create a doctor with MS in trauma is a no starter and a failure from the beginning. Building infrastructure is important, but building efficient operations is more important. I learned that in my training in the US. When I used to be an internist, I thought, oh, it's so easy in emergency medicine. But when I trained again, I realized it's not the structure, the building, or the equipment you buy, but it's the operations. And I learned this quickly from my boss, who always taught me, a fool with a tool is still a fool. What is an emergency department? It's a dedicated area, protected area, secured area, prepared and staffed physical space 24/7. It has zones for triage, resuscitation, intensive monitoring, fast tracks, unmonitored areas where you don't need monitors and intense monitoring of the patient, psych areas where rape patients, abuse patients, suicidal patients can be paired, and surge area if there is a disaster. You need trained staff. You need nurses who understand emergency medicine. You need physicians. Physicians means surgeons too. Physician is a general term for surgeons too. Surgical physicians, emergency physicians, pediatric physicians, technicians, social workers, police, security, a priest for end-of-life care, and support staff are important. The leadership of an emergency department is run by a medical director who assigns the duties to the shift captain. You need a nurses director, charge nurse, you need a chief of security, a social worker on the shift, and a priest. You can have trained nurses, residents, and medical students along with them because they are under training. The art of training is the core of capacity building. Faculty development is important. Every country has to evolve its own emergency system. A US or UK system cannot be fit in India. Faculty have to leave their careers and embrace emergency medicine. Most important, leave their egos. I have always believed in my life that I don't believe in who is in charge of duties. I have always believed in the discharge of duties. Emergency nursing has to be respected. Pre-hospital care training has to be respected. Continuous education is key. How will you educate them continuously? Postgraduate training is equally important, but as in India, we don't have any faculty. The faculty from other specialties like medicine, surgery, anesthesia, chest medicine, leave their careers and embrace emergency medicine. But that means they need to learn the things which they don't know. And that's why faculty development is important. That's why leaving your ego is important. And that's why learning as the residents learn is equally important. We have also envisioned and created a quality training protocol for NABH certification in emergency medicine. National NABH gives a special certificate only for emergency departments. You don't need the whole hospital. They have a separate protocol for that. You can look it up. And that was developed by our team. You can do training nowadays online. You can do in-person training and simulated training. Now, again, Simulation education does not mean simulator or a sim center. You can do simulation without a simulator or a sim center. Again, you need training to learn the art of sim making. It's like filmmaking. You need to be trained as an educator in simulation so that you could simulate using different models. So simulation education means learning the art of simulating circumstances, models, in order to impart education which is acceptable and has outcomes. The roles and responsibilities in operations management need training. Medical director overlooks protocols, develops them. Quality systems, vigilance, maintains discipline on the shift, coordinates with nurses and hospital administration. A shift captain, in absence of the medical director on the shift, leads the care during the shift and reports to the director for any challenges. Charge nurse leads the nursing care. Nursing director is like the medical director, handles all the nurses. Nurses need stethoscopes too. Nurses need to be trained. They do many more things than a doctor can and are great team members. Technicians provide support for EKG, blood draw, splinting, dressings. And you need support staff, of course. This is our hospital. Again, this is a county hospital. That means we cater to indigent patients. And this is our district hospital where I work. This is our 100-bedded emergency department. We see 300 patients a day. Maintaining capacity for quality. You need the development of process and protocols which are tailor-made to your system. You need to know experts who are leaders in patient flow dynamics like a supply chain. When you order something online, how does it reach you in 24 hours? The efficiency of that supply chain makes the company big. The efficiency of patient flow makes it better for the hospital. So if you don't have flow managers who understand patient flow, you will have chock-a-block departments. Electronic medical recording is key because that's how you will make people accountable. You will know who delayed care. You will know who faltered care. You will know who doesn't know how to care. Database decisions are equally important. The future of any system is based on data. You need data, and that's why your systems should gather data. And to maintain any system, there has to be an ego-free teamwork ethos. Everybody aspires to being in charge. Nobody aspires to being the discharge of duties. You need quality improvement, which is continuous. Development of processes need training and intelligence and training to be developed to develop processes to the T, where every second is important. Trauma alert, stroke alert, STEMI alert, airway alert, transport alert, agitated patient, critical alert, toxicology alert, sepsis alert. These are protocols where teams work together, move the patient fast from one area to the other. Order sets for nurses. Nurses can go and put in the order sets if there's a chest pain. They should be able to collect blood, get the EKG, run it to the doctor, put the monitor on. They need to be trained in advanced processes which save 10 minutes, 8 minutes, 5 minutes, 10 minutes here and there, when collectively they save hours. Training nurses and approaches to good triage and resuscitation teamwork is key. First of all, we need to train them on vital signs. Vital signs means temperature, pulse, blood pressure, respiration, and blood sugar at the bedside. The day we train them, they become masters of diagnosing emergencies earlier. And the biggest delay in emergency care across the world is urine examination. People delay collection urine. So if you don't collect urine, you will never be able to run an efficient emergency system. It looks very small, but it's like salt in food. Without salt, the food is tasteless. Preparedness training, team training, and metrics for other departments to hold them accountable. When you were called, how many minutes did you respond? What did you do? Why did you not come in time? Why did you not admit the patient? Accountability is key for flow management. This is a beautiful trauma center. It can double down. So we can do 2 traumas in one area. This is huge. We have a level 1 trauma center. But because we don't collect data, we go to 2. Patient flow dynamics means alert to action time, consultant response time, sepsis alert time, door to needle, door to DPA, and many other times are monitored for metrics and accountability. Electronic medical reporting is key. All reports are electronic. You can't cheat, you can't lie, you can't erase. Metrics are recorded, actions are recorded, results are recorded, care is recorded. Ultrasound images are stored. And we have bedside laboratory called point of care lab, where we get a CBC Chem8 within 1.5 minutes. Data-driven decisions is all dependent on data is key. Performance data, near miss data, where you missed actions which could kill the patient, metrical data, assessment of how you modified the system and how the system is faring now, and vigilance and feedback are all driven by data. Teamwork is key. Non-physician workforce is the key. Team concept is the key. We need to develop a culture of connecting competencies for complete care. You need to go together to grow together. Advanced nursing competency building is key to the efficiency in emergency department. Suturing, ultrasound, Foley, tube placement, ultrasound guided IV are all nursing procedures. They can be done. Simulated based training initiative involves nurses, doctors, procedural training, interventional training, communication training, team building, in situ, on-site, emergency, surge capacity. Simulation is huge. Hence, learning the art is more important than to have an art gallery. This is the way we train in teams, just a visual. Continuous quality improvement, again, is data-driven. Look at lapses as opportunities to improve. Individual feedback, group feedback, and modifications are key. And you gather data, you will be able to monitor and improve. And always remember, wellness focus is key. If you are not well at work, you cannot treat the ill at work. This is where we work. The beautiful city of Sarasota resembles Kerala, beautiful beachside waterfront state. And this is my Twitter handle. Thank you very much for your time. It was a great honor listening to everybody. And I hope you all can visit us. This is the center where India belongs. Our faculty are very much engaged in India. I am engaged in India. I spend 4 hours every day. I have a complete understanding of the core fundamentals. Hence, I did not waste my whole career in developing infrastructures. I spent my career in learning operations and implementing them. The difficult task of bringing MD and DNB emergency medicine, the difficult task of building training models, the difficult task of building processes and quality certifications, because here you need to change minds. That's the career I adopted because it was more difficult, and I think I needed to climb that Everest alone. Thank you very much, everybody.
Thank you, Dr. Sagar. And any questions to Dr. Sagar? Excellent speech and excellent talk. And it's really always motivational to hear to Dr. Sagar. And being with him, it is a journey. And still we are moving ahead in our journey throughout our life. Any questions? And it will be a pleasure if you ask some questions to Dr. Sagar.
That is our hospital behind. You can see that.
Dr. Venkat can't hear. Dr. Venkat, Dr. Vishwanath can't hear. Can you hear, Sagar?
No, I can't hear.
Sir, you are muted with Dr. Vishwanath. We can't hear you.
I can hear you.
Yeah, so it's a problem with the audio. Is it okay now?
Yes.
Yeah, thank you very much, Dr. Sagar, for enlightening us on how to go about with capacity building. And it was indeed a pleasure to listen to you. And one aspect, as you rightly said, a fool with a tool is still a fool. So we need to know the basic, like we have to have vision of what we are going to do. Thank you so much. Thank you.
So now we'll move on to the next speaker, Mr. Venkat. He's the advisor of health, Government of Andhra Pradesh, and advisor, Home Department, State of Telangana. Welcome you, sir. It is an honor to invite you. And you're going to speak on the role of leadership and innovations. So
Yes.
we are eager to listen to you, sir. Please go ahead.
Thank you, Dr. Bhai. Thank you, Dr. Rajan and Dr. Vishwanathan for inviting me. I have been a corporate CEO till 2005 for a German multinational. I did not know anything about emergency nor medicine. when I became first employee and CEO of EMRI. At that time in 2005, no access to 108. There was no availability of an ambulance. There was no affectionate care in the ambulance. It was not affordable. From that time, 6 years later, running 3,200 ambulances in 12 states, every day handling 1,000 lives, having conducted 100 days, I feel there was role of leadership and innovation. During those 6 years, I went to Shock Trauma Center. I went to other simulation centers in Pittsburgh. My dream was to see something what happened today in Kerala. I'm extremely happy and proud that Kerala government has done this, though they couldn't do it 108 in 2007 despite attempts from the current Chief Secretary, Mr. May. We have done much bigger things now in setting up this Apex Trauma and Learning Center. Leadership and innovation are basically two sides of the same coin. I must say that EMRI, I've innovated the number 108 itself. There was no number 108 before. 1 plus 0 plus 8 is 9. Single digit, luckiest number. If you use the word friendship, A is 1, B is 2, C is 3. If you add up like that the values, for friendship it comes to 108. Friendship is between two people, love and love. When you love each other, LOVE is 12 and 15, and those alphabets come to 54. You love me and dial 108, and I love you and take your call and provide you pre-hospital care. 54 plus 54 is 108. Starting from the innovation 108, building an infrastructure of an emergency response center, technology, how to identify calls and how to transfer, how to send an ambulance. Then, of course, the ambulance design itself. What are the differentiators? Why only one stretcher? Why not 5 stretchers? Why not oxygen cylinder below the driver's seat? What patient wants is oxygen, not cylinder. Same way, extrication tools to remove the patients. Like this, the ambulance itself was innovated. And then the pre-hospital care, calling driver as a pilot. Why should I not call? Then the pilot said, who is a driver? I will not drink or drive. I will not, take tips from the patients if I'm a pilot. I will do teamwork in lifting the patient. All this happened with a small change of a title in calling driver as a pilot, despite many people resisting at that time. So the innovation is not overnight, it doesn't come. It is a fruit of, it's not a moment of brilliance. It is a fruit of integrative approach of various people. In this case of EMRI, emergency medicine is not alone. There are processes, there are technologies, there is infrastructure, there is fleet, there are people, there is training. All these people coming together with innovative practices came to a sustainable model of delivering emergency response services through 108. Now let me go to PPP. This is done in PPP framework. First 70 ambulances were done as a private party of EMRI, spent money on capital expenditure, spent money on operating ambulances first 1.5 years. Then the government came and funded now. From 70 ambulances, we went to 700 in one state. Then Mr. Modi heard about it, went to Gujarat. If it took 4 months in Andhra, Mr. Modi said, I want to do in half the time. We did exactly 27th June 2007, I met him. 29th August 2007, I launched first lot of 60 ambulances. In less than a year, we completed entire state. So it is basically the PPP is essential to go to the complete population of a state. Though it's a public-private partnership, according to me, it's also painful, pleasurable partnership. There is pain sometimes to deal with the government, but there is a pleasure also to deal with the government. You have to tolerate one of them to get the second one. But basically, I define PPP as political will coupled with public servants' involvement. like what Rajiv Sadanand did or his successor, now what Dr. Rajan has done, that kind of involvement of a public servant coupled with public support, then only a PPP will be successful. According to me, PPP in healthcare, if it is doing something good for poor, if it is something doing good for pregnant women, but it requires passion, patience, and professionalism. That's how I define PPP.
Sir, one suggestion.
Leadership in emergency care
Sir, excuse me.
is not charisma. Is not good look. Yeah.
Sir, there's your audio is breaking up. So I would request you to cut the video so that the audio can be better.
Okay, maybe it is too close or far or just now. Can you hear me now? Can you hear me?
No, sir, the audibility is like it is breaking. So if you could cut your video and just have the sound track, it will be good enough.
Okay, fine, fine.
Bandwidth may be low. That's the reason why the video is taking too much of this.
So maybe the mic sound is higher. I will reduce the mic sound. Can you please see now?
It's okay, sir, but the video, if you can cut your video, the audio will be more clear.
Okay. Yeah, okay.
Yes, sir, now it's clear.
Yeah, is it okay now?
Yeah, it's fine, absolutely.
Okay. Fine. Now, having spoken about role of leadership and innovation, having spoken about innovation and PPP, let me touch upon role of leadership in emergency care. As I was saying, it is not charisma, it is not showmanship, it is not public relations. It is performance. You have to jolly well reach in time and save a life. It is consistent behavior, whether it is daytime or nighttime, first patient in the morning, last patient in the night. Behavior from the ambulance staff has to be exactly same, and the patient has to trust him. So leadership here is consistent behavior, trustworthiness, and performance. And what I did in EMRI was, I strategized, I visioned, first of all, saving 1 million lives in a year. I saved 520,000 lives in that when we went to 12 states. Strategized what we should do, what we should not do. Never ever we carried a dead body in the ambulance. Number 3, it is aligning people to gain their commitment. People in the sense my employees as well as the government, aligning them, motivated them, energized them. This is a role of leadership. But particularly in a life-saving situation like emergency care, what is required in leadership at every level, including at ambulance level, is humility. Patient is bigger than me. Competence is much more important to produce results here. If you are somewhere else, doesn't matter. Here, competence is important. That's why whom you recruit, how you train him. Proactive approach, professionalism, more importantly, passion to serve people. We used to recruit people by showing them some films and pictures and then select them. This is leadership in emergency care. Leadership and innovation in EMRI, what it gave me was, while delivering a service, you get a joy of giving back to society. That joy of giving increased my dopamines. As a result, my satisfaction went up. Increased my oxytocin levels, it improved my attachment. It improved my frontal cortex activity. It made me adhere to the morals and ethics. What is important in emergency care is sticking to values. First one is integrity. Humility, honesty, courage, and congruence will give you integrity. Second one is the character. What I do privately or publicly, exactly same. Third value is trust. Am I getting trusted for my integrity, for my positive intent, for my competence, for my outcomes, what I'm producing? Lastly, truth. Despite working with 20 chief ministers in 14 states, I told truth at any level. Whenever I was asked to tell, I didn't compromise. I didn't use any diplomatic words, but in a humble way, without hurting others, in an assertive way. These values I practiced now, despite having worked with different politicians, different value systems, but I still did not compromise my values because public have to get benefited. Philanthropy, I want to add one word here. Philanthropy is not checkbook writing. It is much beyond. It is not photo opportunity. It is not washing sins. It is not washing guilt feelings. It is basically not a favor to society, but it is supplementing governmental efforts to take programs in a multiplied way. That's what Tata Trust is doing. Because I feel philanthropy is contributing to enlarging well-being of every citizen in the country. I would like to close by saying my contribution to society today, having left EMRI 108 after 6 years in 2011, last 10 years, I have been developing leaders. I have been sharing my knowledge. I have written a book as per the advice of Dr. Kalam. And more importantly, I produced 3-minute videos on life skills, managerial skills, and leadership skills. So far, I uploaded around 32 of them out of 108 for the benefit of the students and managers and leaders in healthcare. What our Prime Minister told me when he inaugurated the building on 1st April 2010, emergency care is a system where it is a symbol of governance of that state. It is a symbol of speed. It is a symbol of respect. It is a symbol of trust. What Kerala did today is symbol of respect, symbol of trust, symbol of governance, symbol of speed to the citizens of Kerala. I'm extremely proud of Kerala government and its officials, and I thank you for having called me to speak on this occasion. My best wishes, and I appreciate all the speakers. Fantastic insights. Thank you.
Thank you, sir. Thank you, Mr. Venkat. Thank you, sir. And now we move on to the next speech by Dr. Sriram. Dr. Sriram is a senior consultant in Tata Trust. So, Dr. Sriram, are you there, sir? Dr. Sriram? Yes. Please go ahead, sir. You can start. Dr. Sriram is going to speak on National Trauma Registry, Simulation Technology and Capacity Building.
So I'm trying to share the screen. Just give me a second.
Sure.
You're able to see?
Yes, sir. Yes, sir. We can see and we can hear you. Please
Yes,
go
sir.
ahead.
I'll just keep it short, very short. I was speaking to Dr. Vinod Menon, and we agreed that Dr. Vinod will take over and talk about trauma registry. At that, I will share a few of my thoughts on the simulation-based medical education and the way that is going to happen in training, conducting training in emergency and trauma. Well, we are into Kerala, where we have the ATLC now, and I only hope that whatever has taken shape right now, it will deliver the goods and whatever we expect from Tata Trust. So having said that, always believed that, and I think as the rest of us, all of us, we know that public health is an embedded systems of care, and it's a real challenge. You can make things happen in a hospital environment, but you are looking at public health, I think you are looking at big things. So it is imperative, especially when you would want to render the so-called patient-centric healthcare, that irrespective of any discipline, the doctors, the nurses, all the clinical professions they need to be yeah, can you hear me? Yeah. We need trained professionals, let me put that way. I think I have a problem with the net here. So in public health system, the challenge is to negotiate the time critical systems of care in stroke, STEMI and trauma. These are the three things that the country is facing now, with high burden of non-communicable diseases and trauma, for which we require efficient workforce and effective protocols and an effective system to support both. Easiest thing is to be able to identify the life risk related by a medical emergency or a trauma emergency, stabilize the patient immediately, and activate the specialist teams and the trauma teams, and be able to connect and then make sure that the care continuum is maintained. What you require is right skills, people with right skills, be able to render the care at the right time, and then do everything in the right way. To this extent, what we require is standard treatment guidelines, a standardized training, which is going to help a lot. And then this is the only thing that's going to ensure uniformity of care. So thus, we are indirectly looking at a kind of we need to be aware of the situation, the situational awareness, need to have the strategic teams, both clinical as well as operational, and it calls for strategic actions. So when we look at simulation-based medical education, is what is definitely going to address most of the issues, where it makes sure that you upskill people on the critical things, upskill people where they have the knowledge, but the skills for some reason, they are not up to the mark, or sometimes they may be lackadaisical, especially in emergencies like trauma and medical emergencies. This is going to make a world of difference. To not to err is the trick of the trade. And then simulation-based medical education, cutting across multiple specialties and boundaries. It may as well be a part of didactic curriculums in any of the specialty trainings. I leave it there. So all of us, we know the advantage of simulation-based medical education. What I would want to believe is, or every medical professional also, we get carried away with the fact that what we perceive is right, and it may not be equal to performance most often. I may feel that I have those skills to attend to my patients, but they may not be adequate. So there is a difference between self-perceived confidence, which does not necessarily translate into practice. This is from one of the research papers, which says that unless a specialist is exposed to the situations, the skills that are required may not be appreciated. In case they feel that they have these skills and knowledge, they may not be right, and this is going to harm the patients. That calls in for continuing medical education, and especially when they can challenge their skills and test themselves in a simulation environment, which is definitely going to help them to have that knowledge which is self-sufficient, and it will improve the problem solving and also empower them with the troubleshooting skills. So as the American College of Surgeons have propagated, especially in managing trauma across the globe, performance improvement and patient safety is the bottom line, which they believe, and then the same thing is spread across. Well, talk of medical simulation medical education, I have only one thing to say about it. The simulators do not make a curriculum. They are merely tools for a curriculum. the key of this one, the key is the program. It's not the hardware. It is not the ambience that it's there. The mannequin, it helps you when a lot of education is imparted through the mannequin. It all depends how innovatively the trainers will walk the trainees through that. So a good number of examples or a good number of benefits can be shared about a simulation. The best thing that happened last year when Corona hit the whole globe, the basics are big tasks. They cannot go wrong. They're the basic thing. This is what has saved the world. Donning and doffing, medical professionals. People lost their lives initially. Now, video laryngoscopy, trying to play with it in a simulated environment, not getting exposed to the aerosols, not getting infected, then going into the ICUs or wherever they are required to go and do the intubations. Placement of central lines. These things have caught up. The training has caught up in a big way, and more so simulation. Well, that's the best advantage that we have seen in the recent times. So whatever we have done or whatever we have started in Kerala, trying to invest in a simulation laboratory and then an EPIC center for training based on simulation is the best thing that ever has happened. Well, the interns, especially, it's a time for them to take advantage of such things where they can practice their skills and go back to save emergencies in pneumothorax and ARDS. And then especially in handling time critical emergencies of STEMI, stroke and trauma, they can exercise their skills and procedural skills. Very importantly, the crisis resource management skills. That's one advantage. I would not elaborate on that. Continuing medical education, simulation will definitely help. Helps in self-assessment, not only trying to assess the trainees. Very importantly, it's a lot of clinical significance. We can see that the short-term engagements in clinical rotations and time constraints because of various reasons and missed opportunities, they do contribute to less clinical time and opportunities for learning. When that happens, you have a simulation environment where you would want to make sure that you don't lose out on others. That's where simulation centers with simulation training would definitely help. And one thing that has been there since decades, that patients also reasonably would not expect to be subject to practice. That's the reason simulation will is going to be the order of the day. So various modalities of simulation we have around. Very interestingly, have standardized patients or simulation participant with the call. These people, which when they play the roles of patients, they can tell you the stories. And then these things, when they combined with the high fidelity mannequins and all, both these things together in a hybrid environment definitely will add a lot of value, especially in psychiatric emergencies and also in gynec and obstetric emergencies. We are growing beyond mannequins where we can use including high fidelity or low fidelity mannequins. Now, these are the era of internet, information technology and health technology. We've gone into virtual simulation. We can use gamifications. There are virtual realities, which can convert the mollages, which you usually use to train people. And lastly, the debriefing part of it, where people learn in a simulation environment, then practice. They can go back and try to audit themselves. And of course, an instructor with the help of an instructor. And this kind of environment, when you can support with a technical support units with medical oversight, that's what definitely will ensure a care continuum. this may be, I think, maybe way forward. So I thought I would share lots of models of debriefing, but as possible of time, I will just skip all these things. And so I would want to, before I part, I would just want to share about the kind of simulation environment we try to create in the Apex, in the ATLC. We have 2 simulation labs here, 4 smart classrooms, where you can connect faculty across the globe, all the leading consultants and significant people, and 2 consoles for medical control, and 2 of the debriefing rooms, and good number of mannequins, almost close to 110. And we have the greatest asset, 6 of the emergency physicians who are spending a lot of time. They were able to create the right kind of curriculum and the content. They already started training the doctors, nurses, and also nurse assistants. And then they're assisted by 6 of these emergency and trauma nurses helping them out. They have created courses for nursing essentials, emergency nursing, basic emergency course for doctors, and advanced emergency course, an emergency trauma course for nurse assistants, and best part is the training of the trainers. The model is this cascade model, and we are assured of regional training. And as a part of the program, it's possible that we may want to conduct a health impact analysis to understand to what extent this kind of training is going to help out. There may also be an element of reflective training that we might want to bring in emergency, connecting emergency trauma clinics virtually. That also can happen. And these are the days of comprehensive primary health care, where Government of India under Ayushman Bharat in comprehensive health care, they're seriously looking at emergency and trauma care, making sure that the community health officers or mid-level health providers, they're trained in recognizing the life threats and also stabilizing initially and connecting these patients to higher care. So when that is the challenge that we have, I think it's the right time that we had an institute of this kind. And definitely ATLC is going to play a lot of role in bringing a paradigm change in upskilling the mid-level health providers and the doctors who are at the bottom of the pyramid at the primary health care level. A way forward to make a real impact and making sure that we'll be able to conduct a refresher trainings so that people would want to renew their skills at regular intervals of time. Of course, all of us, we do understand, appreciate that training is not a one-time activity. It has to be a continuous activity. Is it possible to look at mobile skill units to be able to, in a mobile environment, take it to places where it may not be possible sometimes for people to be able to report to Thiruvananthapuram, come down to the city and spend some time. You should be able to make some difference there. I thank you very much for all the time. It was great listening to the senior most people from various disciplines. And thank you on behalf of Tata to everyone, Government of Kerala and Kerala Institute of Health Sciences, and all the consultants and eminent personalities across the country for giving us an opportunity to be able to participate in management of trauma and emergencies. Thanks a lot.
Thank you, sir. And it was great listening to you. And your thoughts are well taken, and it has to be a sustainable model so that mobile skill labs are should be a reality. And the concept of simulation is important rather than center phenomena. It is a science phenomena. And similar projects right now we are doing it in Arunachal Pradesh as a WHO collaborating center at Mechuka, where actually near the China border, where there is no connectivity and still the trained nurses, Arunachali nurses, local native nurse, right now training the ANMs, ASHA workers, and also the emergency nurses there for basic skill training by using local, customized task trainers. Even they're using pillows, which we sleep, as giving a CPR. So because of resource constraint, yes, these learnings will be definitely replicative and scalable in other parts of the country. And I also, give my thoughts. I wanted to share with you because you have done a great job, Tata Trust, in actually doing a great leadership role in Kerala, and I'm sure it will be also helpful in other parts of the country. Thank you for your great vision, sir. Thank you. So now I'll invite Dr. Vinod Menon, for the last lecture of the day, and over to you, Dr. Vinod.
Thank you. Can you see my screen? Hello?
Not yet.
Okay. Let me just go back onto it. I think Dr. Sriram's screen is still on there, isn't it? Is that part of the problem?
Maybe Dr. Sriram, your screen is open till now?
No? Okay.
I stopped the video, sir.
Okay. No problem. Yeah. Let me have a look again.
Yes, now we can see.
We can see the screen.
But this is the previous presentation, so let me just go back to it. Is that coming up now? Or?
Yeah, we can see it now.
Yeah.
You can see it now. Thank you.
Please go ahead.
Perfect. Thank you. Thank you again for the second opportunity. Last but not the least, quite an important area about data collection and national trauma registry. We've already talked about engagement of private sector, makes my talk easier and shorter, and a little bit about trauma clinics. Now, I think going back to this slide, which I used previously, why do we need a registry and what does an ideal registry look like? What does it need to capture? All the elements, pre-hospital care, resuscitation and shock control, any delays in any treatment, particularly operating theatre, how do specialties work in a multidisciplinary manner, integration, and certainly, as we've discussed time and time again this afternoon, the lack of rehabilitation services. So the registry needs to capture that. This is a very broad data set used in quite a lot of the Western trauma registries, and I'm pretty sure this is what happens in India too. The demographics is absolutely important, the type of injury, what actually happened, the initial observations, the physiological changes, the transport from the scene, how did the injury happen, was there any safety devices used, continuous observation of physiological parameters, and certainly a good scoring index. A Glasgow Coma score is one of the important ones. But what happens when patients arrive at hospitals? What happens during the transfer? And then any emergency procedures, any radiology, the injury severity scores, whether the patient needs to go on a ventilator. If so, how many days did the patient stay on the ventilator? What was the ultimate outcome? And certainly a good emphasis on rehabilitation. So there is no set pattern to this, but this covers the minimum data set needed for any registry. Why do we need a registry? And I go back to this data from the Transport Research Wing of the Ministry of Roads, Transport and Highways. And if you look up here, this is 2015, the number of patients who unfortunately died from road traffic accidents is about 150,000, 146,000. But if you look at this publication, which is in the Lancet about 12 months back, with an impact factor of 16. And this is with the full support of ICMR, the Department of Health Research. It says in 2017, the number of road traffic deaths in India was 218,000. And I looked up the Ministry of Roads, Transport and Highways website, and it says 150,000. So there is a discrepancy. The reason for that is that if you look up here, the methods of data collection is from verbal autopsy data sources, and the Transport Ministry is from the police records. So there is a discrepancy in the number of cases captured, and we need to standardize this. We need to minimize the gap, hence the need for a registry. So the registry should include all major trauma, not just road traffic accidents. There should be good data quality coordination. It should compare processes of care. There should be definite benchmarks, should compare outcomes, and that should be risk stratified outcomes, regular and informative feedback. You make meaningful comparison between patients and institutions, like I showed in my earlier presentation, and you have to provide high quality reports and publications which would influence capacity building, which is what we've been talking most of the afternoon, and finally improve the clinical care to patients. This is the TARN database, which my good friend and colleague Ajit Abraham mentioned in his talk earlier on the day. This is a trauma audit and research network, and look at the quality and the diversity of publications that came out just during 1 year. And this is only possible if you have a good registry, a good database that is matured over a period of at least 5 to 10 years. But the good thing, there's excellent publications, so we don't have to, there's lots of examples we can look at while we design our structured national registry in India. There's the Australian Major Trauma Registry, there's a German one, and this publications was very exciting, and I read through this, published in the World Journal of Surgery from India in collaboration with Australia Trauma Systems collaboration. And it's really good data, and we just need to refine it, make it better, and standardize it, and roll it all through the country. That'll be great progress. The New Zealand Trauma Registry, New Zealand is a small country. The population is 6 million, whereas Kerala has got 34 million. So that's a comparison. But the Trauma Registry in the New Zealand only started last year. So we're not a long way behind the curve. And they've already started producing an annual report, the first one. They've produced excellent resources and guidelines, started doing the publication and using educational material for meetings. In terms of private sector engagement, we have heard a lot about this. I think the one that I've highlighted here in Kerala, which is well known for its high performing key performance indicators as compared to several states around the country. And we've heard about this all afternoon, about a well-organized healthcare network that exists in India. The private sector accounts for 70% of the facilities and 60% of the hospital beds. So there is no solution to any health problem out of the private sector, and they need to work with them. In terms of collaborative working, ATELC provides an excellent training opportunity to have that symbiotic relationship. They should complement each other. There should be joint appointments, sharing of staff, and we've now seen with the pandemic, even with the vaccination program, the public sector is private sector is standing shoulder to shoulder with the public sector, and that interface needs to be made even smoother. Mature conversations have got to happen. There's plenty of corporate social responsibility funds for the right reason. The trauma network would be a good starting point, and the private sector can very well contribute to cause. Should participate in the registry, and there should be joint publications and joint ownership of the registry. Very finally, about trauma clinics. In terms of rehabilitation, we all know that road traffic accidents and other major injuries affect people in the prime of their life, in the productive life. So once we save their life, we got to make them return to a productive environment and improve their livelihoods. And if you look at this simple slide, the Chartered Society of Physiotherapy, Occupational Therapists, Speech and Language, Life After Trauma. So this is something we have heard from speaker after speaker this afternoon. We need to put some focused attention into improving this. Finally, I would leave this with one statement. Pericles, as you know, is an ancient Greek statesman. What he said is, what you leave behind is not what is engraved in stone monuments, but what is woven into the lives of others. And the Apex Trauma and Emergency Learning Center is a fantastic example of how what we have all been doing there, leading to the inauguration today. The journey is only just starting. What will going to happen there will be woven into the lives of others into the future. And let's all work shoulder to shoulder and make this a great reality. Thank you.
Thank you, Dr. Vinod, for the perspective on data collection, trauma registry. I'm sure we do not have much time for any further questions, but I fully agree with you. And I'll share you with some of my concluding thoughts, and based on experience, based on involved in the national policy, and hearing all the speakers, because we do not have much time for, again, a roundtable dialogue. So if you all agree, then I'll conclude, by summarizing the whole webinar. So thank you very much, Dr. Vinod. And I'll say that the webinar was an excellent, excellent sharing of knowledge and thoughts, which we had this evening. And it was opened up by Dr. Vishwanathan, who, along with the team like Dr. Achil, Dr. Srikanth, with leadership being provided by none other than the Chief Minister of Kerala and the Health Minister, Shailaja Madam, and with the dynamic and able leadership of Dr. Rajan, who is the Principal Secretary of Health, with his visionary words for what we expect 5 years down the line in state of Kerala. It actually set up the ball rolling. And Dr. Rodrigo, actually put the perspective of actually what it means, the WHO World Health, he reiterated the WHO World Health Assembly, we said for a integrated emergency care system, which includes trauma, and to take care of acutely ill and injured, rather than systems in silos. And it was related by Dr. Patanjali Dev Nair, who actually spoke about how to strengthen what is the strategic directions to integrate emergency medical services in primary healthcare setting, because we know that most of the people will not go rush to the main cities, but actually the feeding centers, the district hospitals in state of Kerala and across India, where actually in the rural sector, most of the 70% of population lives. So whatever we have, the neighboring good hospital is the district hospital, PHC, CHC, district hospitals are the, and also now health and wellness center. We need to have an integrated approach, and that is what we have proposed in the national policy, which is coming up from Government of India, both in the primary healthcare setting as well as in the tertiary care setting, in an integrated approach. And it also speaks about the development of a robust pre-hospital care system across India with a good pre-hospital notification, with monitoring and evaluation, or by setting up the national key performance indicators. It now has been developed by the group, by the expert group, and it will be disseminated across the states, across the India, both in pre-hospital care and in hospital care. National key performance indicator has been developed, which was aptly deliberated on by Dr. Vinod Menon, when he told about a very important aspect of key performance indicators for monitoring evaluation. And with the state perspective by Dr. Achil and Dr. Ravindran, he along with Dr. Rajan, described about what is the current status of trauma care and in state of Kerala. And actually we're doing a good job. But the target we have to remember is we have to have the target of reducing mortality by 50% by 2030. I think the whole team is geared up, and see this event only tells the fact that how serious the government of Kerala is, by bringing up both national experts and global experts who wants to make a difference. And the persons who are on the ground actually are making a difference. We just have to work together, as nicely put out by Dr. Vinod. Menon. And this evening could have been much better. It was beautiful because the important CSR contributions by the Tata Trust, and which was very nicely put it by Srinath ji and the other colleague who is speaking on Tata Trust. It is really very nice, sir. And the model which they have developed for other like Cancer Grid, I know that they have been a huge contribution in creating Cancer Grid across the nation, because I know that work, and it will be nice if they translate that in creating a model in Kerala which can be scalable in the country. Because anyway, there will be a national policy which will be coming, very soon, because the gap analysis, we have submitted the report to the NITI Aayog, and very soon you will see as a policy, it will come for, investing a lot on emergency and trauma care, and relooking the issues and challenges of 10 years of trauma program by Ministry of Health. So we also have done a gap analysis on that. So now one milestone achieved. So it is not the trauma center concept which is important, but trauma services, quality trauma services in an integrated manner it should be the mantra, rather than having center phenomena where you don't find human resource and equipment, or equipments are lying idle, human resources are not there. If they are not trained. So that is the things which came up with discussion. And in the last session, we had a really nice session where Dr. Sagar put it out, the capacity building part by Dr. Sagar, with emphasis of development of academic emergency medicine departments. And I'm sure acute care surgery is another discipline which is very important for continuum of care. And third is pre-hospital care science. It needs to be developed in our country. And we have already put that in the policy with the daily development of academic pre-hospital care discipline, like you have EMT basic, intermediate, and advanced. Development of HEMS, we are already there in the policy, national policy. Development of air EMS or HEMS service in India, in the difficult terrains of India, like you have northeastern states, there are hilly states, and even in Kerala, somebody is saying in the hilly regions, you require air ambulance, not only for VIP service, but I say VIP for the patients who are living in difficult terrains. So that is already there in the policy, and it will be executed. And also development of, say, boat services, boat EMS services in the water bodies, that already has been proposed in the document. So, the policy is focusing more on developing a good access to emergency and trauma care as well, and in hospital care. So that is what, and that is what is being done nationally. It is going to come, and I'm sure that rehabilitation is a key issue, which is already there in our national trauma policy. It is coming as standards that rehabilitations, is a phenomena which will be there in tertiary care and also secondary care level hospitals across the country in trauma care facilities in level 2 and level 3. Also with basic facility, level 2 and level 1 will have much improved facility across the country. So the trauma care standards are coming. That is number, what should be the standards for trauma care facilities? It is going to come up very soon. It is right now in the passing of the approval from the ministry. Second is national trauma care standards. They are already been done by the group, and it is going to come. So there will be standardized care across the country. Third, a national key performance indicator has been already made and going to be disseminated across the country. Implementation is the key issue, and I'm sure, with support of everybody, I think we should be able to implement that, in such a, open mind, innovative, positive, people of Kerala, and all like-minded people across nationally and globally. So with this, I thank the whole team of the speakers in the evening, those who are present and those who have left. I thank all of them. Now I hand over for final words to Dr. Vishwanathan, because he is the key person, along with his team to take it further. Just final comments from Dr. Vishwanathan and we can close. Thank you very much.